Welcome, Bokkel. What do you mean by win? I'm still setting things up. Welcome, Oily Olive. I'm still setting things up. Welcome. Absolutely. COVID still matters. Alright. I actually, forgot my starting screen today. A little bit off my game. But welcome. Welcome, Bakul. And welcome, Oily Olive. And anybody else who's tuning in. As usual, I'm Corey Campbell. I am back for a second day in a row. I streamed yesterday. Had a conversation with a YouTuber, the Juggling Vegan, speaking about veganism, advocacy, a bunch of other things, which I very much enjoyed the conversation. And if you're interested, you can check the VOD on Twitch, and there's also on YouTube. I now should have VODs going up to YouTube as well. Let's see if this works. Yeah, exactly. My YouTube channel is there, along with my other social media links. Thinking about it, vaccine does not read. So I'm not 100% sure what you mean, Oily Olive, by that the vaccine does kill. I don't know that there's very many, or I think from what I recall reading, there's really only like a very small handful of deaths like directly linked or associated to the mRNA vaccine. There are totally some deaths associated with some of the other sort of viral vector vaccines, like the AstraZeneca one, Johnson & Johnson, etc. But even then, that's mostly like as a result of a complication from like blood clotting, etc. But from what I understand, the mRNA vaccines have like very few or any sort of death associated with them is exceedingly rare, based off of the data that I've seen. So yeah, on today's stream, it's going to be pretty much exclusively a science stream, or some news articles as well. My weekend has been pretty routine and uneventful. I've been pretty much going to the gym, trying to get back into a routine. I actually can't work out my lower body due to the infection that I still have in my foot, that it looks like I'll be requiring some sort of minor surgery to deal with that. I think to pretty much drain the infection and like clean out the wound. And like I'm actually in the process of like finding a surgeon, and that seems to be pretty difficult so far. All of the surgeons that I've attempted to consult, they say like they don't do that type of like operation. But yeah, the search continues next week, for at the very least a surgical consultation. That's pretty much like the update on my life, trying to like, you know, get my health back under control, or like somewhere back to baseline, or actually feel hopefully more like my usual self. The fact that I have this like infection keeping me, holding me back from like working out my lower body heavily, doing any sort of like cardio, because I basically can't really have any sort of friction or large amount of pressure in a certain area on my right foot. And so I'm like trying to like adapt my workouts to that. But as I've like mentioned before, not the end of the world. I can deal. Just, you know, at this point, a pretty significant inconvenience in my life. I'm just gonna set up a few other things. One moment. Okay, yeah. Sorry. I'm a little bit distracted from a bunch of things. So, yes. I also, you know, had some spirited discussion yesterday on stream. You know, the vegan conversation, and watching other vegan content creators seems to really bring out a lot of passion in certain chatters, which is fine. You know, I like spirited discussion and debate as much as the next person, but I just find it so interesting that, you know, somehow veganism really seems to like trigger people to a large extent, and I'm not sure why. Like, technically, I'm not even vegan, and like I have no problem watching vegan content, and I don't get triggered by it. It's a medicine problem. People think the medicine is good enough and slowly stopping using the other measures that help prevent it. Example, if you have a cold, you try to keep warm, or in COVID cases, distance to wear a mask. Yeah, so what you are alluding to, Oily Olive, is complacency. As in, I think for maybe the vast majority of people, probably myself included, COVID is no longer like at the front of your brain. It's just kind of like in the background, or for many people, maybe a little bit myself included, we have just like moved on and have forgotten about it. It's no longer making major headlines, from what I can tell. It's not that I watch really CNN, but of the few CNN clips that I see, there's no like ticker going on, or like there's no graphic saying, hey, here's the number of deaths now for infections of COVID. It really is just like fading into the background more and more. And yeah, you are correct. I agree with you that, we can't rely on the vaccines alone at this point, still, unfortunately. And that depending on where you are in the world and your specific circumstances in your region, you might have to take other precautions. I can only speak for my area, but, we are very clearly seeing a surge of the, the BA.5 variant. And even of the surge that we are seeing and observing, like, we are confident that it's underreported because we just don't have widespread testing anymore. In my area, and I'm pretty sure that's most areas, we're relying on self-reporting, or just people testing themselves, ones who happen to, feel the need to report that they're infected. And Myopic Times, welcome back. Thank you so much for passing by. Hope you're doing well. Thank you for all the great questions and exchange that you brought yesterday. Talking about how the vaccine is a government plot to let free thinkers die from a virus while they protect all the sheep with the vaccine that has a... Yes, that's exactly what this stream is going to be dedicated to. 100%. But yeah, like, the two main things that I intend to cover on this stream is one, okay, in the title, I'm going to be covering a cancer case report. This was requested specifically by Bill, fellow streamer, fellow follower. I should give them a shout out. I believe that is their... and Matt Luther, welcome. Thank you so much for passing by. And yeah, it's been a minute. Much appreciated to have you back. So we're just gonna like dive right in. I'm gonna cover this afterwards because I want to get right into the cancer case report, because I gave my word to Bill that I would cover this cancer case report because they asked me to, because it directly relates to them without giving away too much information. They have a personal friend that, unfortunately was diagnosed with cancer, and like this case report highlighted here, it's literally about their personal friend, someone they know personally, where it's like they got a diagnosis of cancer. It seemed to be resistant to treatment, and it seems like based off of like this sort of, at the time, experimental treatment, they had a pretty miraculous recovery. As in, it seems like, even based off of what's outlined here in the case report, that like the survival rate was like projected to be low, and it was looking pretty grim. And then like this kind of like Hail Mary treatment attempt appeared to like work. And like Bill is still in contact with them, and like they're doing well. Seems like, they're pretty much thriving, and like they've essentially have been able to like move on from cancer, and put it behind them, basically officially. And yeah, exactly, Bill Chops. Although I think they have rebranded now to Bill XOXO. Only thing I dislike about vegans is how they do activism. So yeah, depends on what you mean by
Welcome to
advocacy.
Country.
Thank you for the follow, Joe Biden is corrupt. Very original username. No one else has a similar username in Twitch like that. But like, yeah, so there's obviously a certain amount of advocacy that I'm in favor of in terms of talking to people, in terms of, coming to understanding, conversation. I'm definitely not in favor of attacking restaurants or attacking people or attacking anyone in general. That is literally why, I wanted to have a conversation with that vegan YouTuber, because, their type of advocacy, street advocacy, they literally just go out in their neighborhood or in their city or town, and they just have, one-on-one conversations with people in a friendly manner, in a non-confrontational manner. And as we covered yesterday, they try to meet the people where they're at. And that's pretty much like, I don't see why anyone would have an issue with that type of advocacy. So I'm scheduled to get my fourth dose, so second booster this Thursday. Does that mean skin cancer that isn't spreading? No. Metastatic, generally speaking, refers to, like, basically the cancer has metastasized to another part of the body. Let me just make sure I've caught up with everything. Oh, metastat. I see. Okay, fair enough. Best advocacy would probably be helping people start community gardens. And yeah, I can totally be in favor of that as well. Not just even as part of the vegan movement. I think that'd just be a good movement in general outside of veganism. As in, I would be all in favor of having local community gardens spread throughout any city or town. I think that would be a great thing. A wonderful thing. So yeah, this literal case report, it's a case report about Bill's personal friend. Where it seems like, yeah, they had a miraculous recovery. We're gonna get right into it. I'm probably gonna lower the music a little bit. Want to make sure the audio levels are decent. Okay, so yeah, abstract. So the case report was published, like 5 years ago. But I believe, Bill's friend, it basically took place a while ago. And that it was only just published fairly recently. Basically a delay between, when the actual patient was treated and when this actual case report was published. So we report the case of a patient with stage 4, and stage 4, not that I'm a doctor or a cancer expert, I'm very familiar with cancer from, a biological perspective, really at a cellular level. But I'm absolutely no way an expert on treating it, diagnosing it, anything that matters. I mostly just come from I have a pretty good, much higher above average understanding of cancer, and how it manifests, the cellular mechanisms, the cellular, pathophysiology. And so stage 4, generally speaking, is considered quite advanced, as in generally speaking, stage 4, your prognosis is pretty low, and not good. And melanoma, that's essentially, skin cancer, that developed symptomatic disease progression after treatment with combination immunotherapy. I'm probably going to butcher these, but ipilimumab and nivolumab. The patient was subsequently treated with nab-paclitaxel chemotherapy and pembrolizumab, and had a rapid and dramatic clinical response. The case illustrates that clinical responses are possible after progression on combination immunotherapy. So, I'm certainly not an expert in these therapies, other than to say, I know that this is an antibody, I know that this is an antibody, and I know that this is an antibody. And I know that because, generally speaking, anything that ends with MAB often stands for monoclonal antibody. And there's like a whole naming scheme when it comes to engineered antibodies for human therapy, where it's like whether it's a human antibody, whether it's chimeric, etc., etc. As in, this IZU means something. And if I remember correctly, I believe this IZU means that it is a chimeric antibody. I actually want to check that myself, just to make sure I'm not spreading, misinformation. One second. Yeah. I'm not that crazy. Right. So there's the whole naming scheme about antibodies, and they go through it here. Where the yes, as sort of alluded to here, this ZU means chimeric. Yeah, sketches of mouse, top left, chimeric, top right. Oh, okay, yeah. Humanized, bottom. Okay, yes. Etc., etc. But this is getting into the nitty-gritty details. But this is all just to say that these are named intentionally. It is not linked in the Discord. I will actually do that now. I put it in the scientific research and sources channel. So if you want access to it, it is there. So yes. Antibody, antibody, antibody. And so, these types of therapies have been sort of in the pipeline for a while, but they are like fairly recently, in the past, 10, 20 years, really taking off. As of like today, 2022, generally speaking, the most profitable therapies, the ones that, generate the most revenue or money for a pharmaceutical company, is a monoclonal antibody. I think going back about 10 years, like 3 out of the top 5, best-selling medications is some sort of antibody. Because we are, getting better and better at engineering these antibodies. And really, taking a protein engineering design approach to them. Whereas like previously, we had to rely upon like harvesting antibodies from like other animals or other species. Pretty much today, we can, to some extent, not quite there yet, but we can almost like fully customize an antibody. Or like we're on the way there, it seems like. So the World Health Organization estimates that the annual worldwide incidence of cutaneous melanoma is 132,000 cases per year. Outcomes for patients with stage 4 melanoma have historically been poor. Yeah, just as I mentioned in reading the abstract, not only like whatever, cancer in general, not necessarily the best prognosis, but stage 4 is usually, pretty advanced. And almost like universally, for any cancer getting to stage 4, it's a poor prognosis. In the 7th edition of the AGCC guidelines, the median survival for stage 4 was about 8 months, and the 5-year survival rate was less than 10%. However, treatments and outcomes for these patients are rapidly changing. Well, we're probably going to get to that point somewhere down the line. Wouldn't surprise me. The first agent approved by the US FDA for the treatment with stage 4 melanoma was the cytotoxic chemotherapy dacarbazine, or DTIC. Dacarbazine achieves clinical responses in 5 to 10% of patients, most of which are short-lived. The immunotherapy high-dose interleukin-2 was approved for stage 4 melanoma in 1998. So, what does this mean? Or, to sum it up, even with the treatments, okay, the clinical response is pretty low, like a very small minority. And here is where, you would make the distinction of clinical response versus like, clinical remission. As in, yes, clinical response, generally speaking, means like, sure, there's some sort of positive response, but does not necessarily mean that, this patient or this person will be cured of cancer. All it's pretty much saying is like, oh, there is some sort of benefit from this medication that this patient is experiencing. But that doesn't say anything about, the long-term survival or like whether it's curative or not. That's why they sort of make it clear that it's a clinical response, but even that response is short-lived, as in, yeah, there's some benefit, but that benefit does not seem to last very long. And that even projecting forward in terms of survival rate, still quite low. And also translating this, cytotoxic chemotherapy. Cytotoxic basically just means poisonous at a cellular level, as in toxic to the cell. And that's basically what chemotherapy is, or a significant portion of chemotherapy is essentially poison, hopefully, to the cancer cells. But one of the reasons why, very often, chemotherapy has a lot of associated negative side effects is because, these chemotherapies, they are not that targeted. They are not directly targeted to the cancer cells. And so you have all these other sort of downstream or pretty much, side effects. Because not only does the chemotherapy, hopefully is affecting the cancer cells, but it's also, unfortunately, affecting your other, normally functioning cells. Very often, chemotherapy targets some sort of rapidly dividing cell, because generally speaking, cancer is essentially, a rogue cell that is just dividing uncontrollably, and is often dividing rapidly, uncontrollably. What we do, or what our earliest attempts for cancer therapy is just like finding something that's poisonous to rapidly dividing cells, and that's why one of the reasons, or one of the common side effects of chemotherapy is, the stereotypical hair loss, because your hair follicles contain rapidly dividing cells. And so in the process of targeting those cancer cells that are also rapidly dividing, as you are poisoning those cells, your cancer cells, you are poisoning those hair follicle cells. And since they die, you very often suffer hair loss. So the approved immunotherapies include the anti-CTLA-4 antibody, ipilimumab, FDA approved in 2011, the anti-PD-1 antibodies, nivolumab, and pembrolizumab, 2014, and the combination regimen of ipilimumab, ipilimumab, and nivolumab. In the recent Checkmate 67 study, treatment with ipilimumab monotherapy and nivolumab monotherapy and the combination therapy achieved objective responses in 19%, 44%, and 58% of treatment-naive metastatic melanoma patients. So, what this means is basically this is when the patient is getting this therapy alone, and then the combination therapy appears to be the most effective. Still not great, slightly better than a coin flip, but you can still see basically not the greatest odds, but significantly better than each therapy alone. So here we describe the case of a metastatic melanoma patient with wild-type BRAF gene that develops symptomatic progression after treatment with ipilimumab and nivolumab. So, what is wild-type? This is referring to, well, obviously a gene, as they say it. But wild-type basically means your sort of normal functioning gene. The one that is basically not abnormal. We call it wild-type because, you know, pretty much not very creative. It's the gene that's most often found in the wild. Sort of, you know, your stereotypical functioning gene. Your run-of-the-mill gene. So, what happened when this individual was diagnosed with this type of melanoma? So, after 3 cycles of maintenance with nivolumab, the patient noted increasing fatigue. Oh, sorry. I started the wrong place. So yeah, the case presentation. The patient presented at age 11 with a pigmented lesion of the left ear. A shave biopsy revealed melanoma in situ. An in situ just is fancy word meaning in place. A subsequent wide local excision revealed no residual disease. At age 27, the patient presented to an emergency room with complaints of fatigue, night sweats, and weight loss of 1 month duration. Diagnostic testing identified elevated liver enzymes, and MRI of the abdomen demonstrated innumerable masses in the liver, with 50 to 75% replacement of normal liver tissue. So, like, yeah, you can see that, you know, they found something abnormal at age 11, and then, like, 16 years later, you know, they are returning, you know, for medical care and showing up to the ER with, you know, these pretty devastating symptoms, and, you know, pretty much devastating diagnosis. And I'm not going to attempt to read this because I'm not qualified, and it's, you know, I'm not a radiologist, so I have no idea what's going on here, other than, you know, the best I can do is just read the description. So a biopsy of a liver mass confirmed metastatic melanoma. Molecular testing on the biopsy detected no mutations in the BRAF, NRAS, and c-KIT genes, and immunohistochemistry failed to identify expression of PD-L1 protein by the tumor cells. So, you know, I can't give you a full rundown of all these genes. The only thing that, you know, I can say with confidence is I know what they're doing here, in the sense of I understand the reason why they are testing for these things. They are attempting to kind of, you know, get a better understanding of the cancer, and also potentially get a better understanding of how they should treat this patient. Because, you know, if you understand the genetic background, or if you know based off of certain mutations, well, this type of cancer with this mutation, we know that it responds best to this type of therapy. This is the attempt to generate some sort of personalized medicine. where, you know, through genetic screening and genetic testing, and, you know, through research that has taken place in the past, you know, come up with a customized treatment plan. I don't understand how you can get 57% of your liver turned into... Yeah. Well, hard to say, right? I obviously have no first-hand experience with this type of diagnosis, thankfully. And I hope, you know, no one ever has to go through this again. But it is hard to imagine in terms of... and this might just be a testament to how, generally speaking, the resilient the liver is. The liver appears to be, you know, a pretty miraculous or standout organ in our body. It's basically like one of the few organs, if not the only organ, if I remember correctly, that, like, you know, we do this for some liver transplants, where it's like you take half the liver from like one patient, you transplant it to another patient needing a liver, and like you can just regenerate a full liver in another patient by just taking half of another person's liver, right? Like that's pretty incredible. I think that's not only a testament to like the resilience of the liver, but also to like probably how important it is, as in, like, you know, it's clearly very crucial to your survival, and carries out so many functions. And so, like, yeah, it begs, at least to me, it's very curious as to why other organs haven't evolved, you know, this ability, right? Where it's like, yeah, we would want that for like our hearts. We would want that for our kidneys. You know, for our kidneys, we have evolved redundancy. We have evolved, you know, a backup plan. As opposed to like the liver, it's just like we've evolved the ability to like have a high degree of regenerative capacity. I think that's pretty cool, but that's also like, to me, biologically and evolutionarily like curious and interesting. Yeah, exactly. That's essentially our detox center, in addition to other things as well. And you're probably right, that is almost certainly a variable as well. So the patient started treatment with the combination immunotherapy regimen, ipilimumab, prescribed based off of weight, and nivolumab, 6 weeks after initial presentation. So, like, based off of the diagnosis and all that sort of genetic testing and genetic screening, this was their original treatment plan. These two antibodies. At the start of treatment, the serum LDH, this is lactate dehydrogenase, essentially a biomarker. The LDH level was approximately 6 times greater than the upper limit of normal. So they're like going to be using this biomarker to like track the progress, or to potentially be able to determine whether the patient is responding to the treatment. You know, whether there's a benefit or not. The patient's symptoms improved significantly after the first cycle of treatment, and the second cycle was given as scheduled 3 weeks later. The patient subsequently developed symptoms of mild colitis, which I'm certainly exceptionally familiar with colitis, which resolved with oral budesonide therapy. I'm also exceptionally familiar with budesonide. This is literally a therapy that I have been on in the past. That is essentially a steroid, a corticosteroid, but it's actually pretty distinct from other corticosteroids because it's essentially a kind of localized or quote-unquote time-released, where this type of therapy, it's a pill, it's a capsule, and it's specifically designed to be released in a specific segment in your GI tract, where it doesn't dissolve or degrade in your stomach or in your mouth. It's only when it gets to like basically your large intestine does it actually release the medication. It is essentially kind of like a topical treatment for colitis. So standard blood testing demonstrated normal serum, AST, ALT. These are basically liver biomarkers, if I remember correctly, and LDH levels prior to the 3rd cycle. After the 4th cycle, the patient developed grade 2 hepatitis with elevated transaminases, along with fevers and night sweats. And so hepatitis, that's essentially liver inflammation or inflammation of the liver. HEPA or hepatic liver, and generally speaking, in medical terms, anything ending with ITIS basically relates to inflammation. Highlighted here with colitis, inflammation of the colon, hepatitis, inflammation of the liver, arthritis, inflammation of the joints. Antigen. This is not explicitly a MAGA stream. No. And if that lets you down, well, I apologize, but too bad. So, the patient, and this is basically indicating that, their liver is taking a hit. Their liver is, being negatively affected. The patient was started on oral prednisone therapy for presumed autoimmune hepatitis. And I definitely know this medication as well, because that is literally a medication that I've personally been on many times. And that is also a corticosteroid, but that is more a systemic steroid. Contrasting it with the budesonide, that's kind of like a local topical corticosteroid. Prednisone is a systemic, kind of like affects the entire body type of corticosteroid. And they started them on this therapy because they suspected autoimmune hepatitis. Basically, the body is rejecting their own liver, and it's self-generated inflammation. And prednisone is, generally speaking, very effective at pretty much reducing, if not eliminating, inflammation in the body. There's a whole bunch of other negative effects associated with that, but when it comes to inflammation alone, prednisone is very effective at reducing or eliminating inflammation in the body. Democrats turned country... Well, that's your opinion, and I don't necessarily disagree, but at the same time, I don't think Republicans are any better, and if not, I would argue that they are worse. And Bob Marley, welcome. Thanks so much for passing by. I'm wondering why there's no mention of fibrosis or cirrhosis. So cirrhosis is a specific kind of diagnosis, and I'm not sure that they can explicitly test for fibrosis without doing a specific. Yeah, exactly. Cirrhosis is scarring of the liver, right? Very often, diagnosed in people who, have a long history of alcoholism. And, cirrhosis is when you're, on the path to, requiring a liver transplant. Kind of like the point of no return for your liver. Yeah, no. Well, I have. I'm gonna cover, literally, the study that you sent about the vaccine savings lives. And if you want to send the one about free healthcare, totally, I would appreciate that very much. Yeah, exactly. You are 100% correct. And that is literally a test that I have experienced. And so, obviously, I'm not a doctor and I can't say for sure, but I would say it's probably not all that informative, knowing whether or not there's fibrosis, and if you know there's cirrhosis. Well, generally speaking, there's cirrhosis. There's other clear visible symptoms of cirrhosis, but it probably would not change, I suspect, the treatment course, knowing that there's fibrosis, right? If you know that there's elevated liver enzymes, if you know and you're confident based off of just a blood test, another type of screening, that there's inflammation in the liver, knowing whether or not there's fibrosis probably doesn't affect all that much. That is my, lay opinion, because I'm not a medical doctor. I just have, a lot of medical experience as a patient. So the patient was weaned off of steroids. Yeah, also something I'm very familiar with. Where it's like, yeah, when it comes to corticosteroids, you very often, if not always, have to be kind of tapered off of the dose, because corticosteroids, they replace, your own steroid, basically your own cortisone in your body. And so you want to slowly taper off the dose to allow your body to like start generating back its own cortisol. Perfect. Thank you so much. Always appreciated. You provide some great research, Bob Marley. Basically they were given steroids to, hopefully treat the liver inflammation. Then they were slowly taken off of the steroids and then started single agent nivolumab, based off of their weight. After 3 cycles of maintenance nivolumab, the patient noted increasing fatigue, night sweats, and abdominal distension. And that's essentially just, swelling in the abdominal area. Serum LDH was 18 times the upper limit. The serum, again, liver biomarker, was essentially elevated. The patient was anemic, so basically, low iron, or, poor ability to carry oxygen in the blood, more specifically speaking. CT demonstrated marked increase in the size of hepatic and rectal metastases, as well as worsening lymphadenopathy in the X. Well, yeah. But basically, despite treatment, wasn't looking good. And so the patient was screened for multiple clinical trials. So as a result of, despite treatment and the worsening of the outcome, yeah, I definitely know these liver enzymes. I have literally, we actually use these enzymes as part of like the biochemistry teaching lab. Like we have students work with alanine transaminase, because the transaminase reaction is a very important reaction when it comes to, your own biochemistry. So like, as a result of like the worsening of their condition and the treatment not working, they started to look at clinical trials as a kind of last ditch effort, get them hopefully an effective treatment. And so the decision was made to treat the patient with nab-paclitaxel and pembrolizumab given every 3 weeks. So this is another antibody, and I'm not 100% sure what this is. It sounds like a small molecule, and I assume this is, I would suspect some sort of, based off of NAB abbreviation, I would suspect, like a nanoparticle, maybe? What was it spelled? NAB paclitaxel, nanoparticle albumin-bound paclitaxel. Okay, yeah, that makes sense to me. It's an injectable formula. Let's see. Okay. I think I get the gist of it. Paclitaxel kills cancer cells by preventing the normal breakdown of microtubules during cell division. Okay. Got it. Then I know specifically what that means. Okay. Do I want to give a biology, or, a brief biology primer on microtubules? I can probably do that. Okay. So, what is the NAB paclitaxel doing? Based off of that brief description, I have a decent understanding of what it's doing. It is, so one of the reasons why this is a nanoparticle that involves albumin, okay? Yeah, nanoparticle albumin-bound paclitaxel. So, I can't say with 100% certainty, but I have a high degree of confidence. I know why they are sort of using albumin here. This is probably their way of getting the paclitaxel inside of the cell. Because generally speaking, your cell has a cell membrane, and it doesn't let just things freely pass through it, right? Because that wouldn't be a good thing. You want to be able to, just as you personally want to selectively, hopefully, voluntarily ingest what you want to ingest, a cell, it's the same thing. It wants to be selective in what it lets inside the cell. And so if you just use paclitaxel alone, without this nanoparticle albumin bound, it will probably not get inside of the cell. This is basically sort of the key to unlock the door, get inside the cell. And then the paclitaxel can do its job. And the job that it does is it prevents the normal breakdown of microtubules. And what are microtubules? Let's see, where I think I know where I want to go. So microtubules are essentially, I will attempt to show you from a textbook, but in a nutshell. So just as, you as a human, your body, okay, you have a skeleton, and you would not be all that useful without a skeleton. You need a certain amount of rigidity and structural integrity in your body in order to, not only be alive, but to have any sort of functionality as, an organism that, moves around. The same thing holds true at a cellular level, at least when it comes to human cells. Human cells, they essentially have a skeleton. It's literally called a cytoskeleton. That is a biological term. It's a skeleton at the cellular level. And as you see here, they mentioned microtubules, okay? And so that is what the paclitaxel is doing. The analogy would be, is like, if I give you a drug that kind of like dissolves all the bones in your body, I think you'd be pretty confident that you'd be dead, and your survival would go to 0. The same thing holds true at a cellular level, where with this paclitaxel, okay, as they say is the mechanism, kills cancer cells by preventing the normal breakdown of microtubules. And so you are essentially giving the cells something that disrupts its cytoskeleton. And in the absence of this important structure as part of its cytoskeleton, hopefully the cancer cells die. That is sort of like the mechanism in a nutshell. And I wonder if there's a nice diagram in this textbook. Probably not. So I don't want to waste too much time. looking at microtubules, small detail. But this is just my my biological nerd side coming out. I know my alphabet. Micro, M-I-C. Microtubules. Continue. Assembly. 824 to 826. That's far down in the textbook. Well, you're lucky this is an open book exam, Myopic. This is not the most informative diagram. Like, sure, it's showing you microtubules. But it's not really giving you a good idea of what they're doing inside the cell. Other than, okay. Okay, I can work with this. So, this, what you're seeing here, in this circle, this is, the textbook's way of, I guess, depicting a cell. And in green, okay, are the microtubules. And actually microtubules, okay, are, you know, not only important when it comes to, like, structural integrity, but they're also important when it comes to cell division. Okay, and this brings me back to my sort of original point, or what I originally shared of, like, chemotherapy, very often just the overall target is, you know, disrupt cell division, or disrupt cells that are rapidly dividing. And so you can see here in green, you have microtubules throughout the entire cell. But what they're showing here, okay, is the role that microtubules play in cell division. As in, like, yeah, it's coming back to me. This is, like, in the deep back filing cabinet of my brain during my undergrad. Of, like, yeah, microtubules, they play a critical role in cell division in, like, separating the chromosomes, or basically separating the genetic information. Because as part of cell division, well, pretty much as part of cell division, the original cell, it duplicates its genetic information. And then, you know, one half stays with the original cell, the other half goes to the daughter cell. Well, what allows the transfer of the other half of the genetic information to the daughter cell, it's those microtubules. Okay? And so it's like, yeah, if you give a drug that disrupts microtubules, or basically, you know, doesn't allow it to function normally, then not only will it have, you know, other effects as well, but you're also having, you know, a pretty significant effect on cell division. And so hopefully, you know, that cancer cell can no longer divide effectively. And so, like, yeah, this makes sense to me, in terms of, like, a mechanism of a chemotherapy. And the pembrolizumab, this is an antibody, yes, but I couldn't say with confidence what it does, and I'm curious myself. Yes, humanized medical uses. From what I, like, quickly gather, and this is, like, very quickly gathering, I suspect it kind of, like, boosts your immune system, such that your kind of, like, immune cells can also target cancer cells. That is my suspicion. That is my speculation. But I could be wrong about that. And I don't want to, like, you know, bore you by you just watching me read things in my mind on stream. But like, yeah, it's an antibody. Definitely doing something to the immune system. That I can say with a high degree of certainty. And my suspicion is that it's kind of like giving the immune system a boost. In that, as part of your normal functioning immune system, it's actually to, you know, basically carry out surveillance for cancer. Like your body has, well, your typical healthy human being has, you know, anti-cancer properties built in, or cancer-fighting properties built in. And that's part of the immune system, as in to hopefully find and detect cancer cells and eliminate them. And I suspect that the pembrolizumab, I think, boosts that aspect. That is my suspicion. So the first treatment was administered 1 month after the last dose of nivolumab, and the patient reported symptomatic improvement after just a few days. 3 weeks later, laboratory testing demonstrated normalization of transaminases, so it looks like their liver was starting to improve, or, you know, some of the biomarkers of liver function started to improve. And an 85% reduction in LDH. CT scans performed 3 weeks later showed 40% reduction in size of the target liver metastases, along with improvement of the other masses. So that seems like, you know, a pretty like quick and miraculous turnaround. Even just in like, you know, this short paragraph is a little bit of a ride, where it's like, you know, they tried one treatment, the patient was not only not improving, but they were getting worse. And so they started to look for clinical trials, but no clinical trials. Well, they didn't meet any criteria to be included in any clinical trial. And so as part of like a Hail Mary attempt, they tried these two therapies. The paclitaxel, and this other antibody. And it looks like, as they say here, after just a few days, there was pretty significant improvement. And then just 3 weeks later, so like less than a month, there was like this huge turnaround. Which is, yeah, that just reading this, it sounds pretty miraculous. The patient has now completed 11 cycles of the paclitaxel with pembrolizumab treatments. The only side effect the patient has experienced is grade 1 neuropathy. Testing after cycle 10 demonstrated normal liver enzymes, near normal serum LDH, and continued objective response by RECIST criteria. So it's like, it seems like it was not only dramatic improvement, but sustained. And like, you know, I know from Bill's testimony, because this is Bill's personal friend, like, they're still alive today. And it seems like, as I mentioned earlier, like, cancer is pretty much just like behind them. And so, wrapping up, the care of patients with metastatic melanoma has been revolutionized by the development of increasingly effective therapies. The recent approval of ipilimumab and nivolumab has provided a powerful new therapeutic option for stage 4 melanoma patients. And so, like, based off of their description, well, I think it's fair to say at this point, like, just about every cancer has an unmet need for more effective therapies. You know, we definitely are it seems to be the case that we are very far away from curing cancer. And it seems like when it comes to this, melanoma, and specifically stage 4 melanoma, you know, the options are limited, right? Like, there's a huge unmet need. As they mentioned earlier, even with like the most effective treatments, it's like your prognosis is still pretty poor. And yeah, they make it explicitly clear. There is an unmet need to identify effective treatments for patients that are resistant to this combination. Current National Comprehensive Cancer Network guidelines for the treatment of patients with metastatic melanoma recommend the use of a different class of therapy in the second-line setting. For patients with a BRAF mutation that progress on ipilimumab and nivolumab, there are multiple effective targeted therapy options. However, there are currently no targeted therapies that are approved for patients without a BRAF mutation. While clinical trials are a good option, often patients are not able to participate in such trials due to a variety of factors. Treatment with cytotoxic chemotherapy is a potential second-line treatment option. However, many oncologists are reluctant to use chemotherapy in metastatic melanoma patients due to the low activity of dacarbazine, which to date remains the only cytotoxic agent FDA approved for stage 4 melanoma. And so it's like, as of 2017, when this case study was published, and, you know, I don't know for certain, but I think I'm pretty confident that this still holds true today, 5 years later. Where it's like, this is still probably the only cytotoxic agent FDA approved for stage 4 melanoma. So, the patient in this case report achieved a rapid and dramatic clinical response with combined treatment using the NAB paclitaxel, so the sort of nanoparticle albumin paclitaxel, and pembrolizumab after progression on ipilimumab and nivolumab. Although the kinetics of the observed clinical response are consistent with the activity of a cytotoxic agent in this patient, we cannot exclude the possibility that pembrolizumab contributed to this response. However, there is no published data demonstrating a difference in activity for pembrolizumab versus nivolumab, or that pembrolizumab has benefit after progression on nivolumab. There is also no data demonstrating benefit for combining cytotoxic chemotherapy with immunotherapy. It is also possible that the previous exposure to immunotherapy may have contributed to the response, as the potential for prolonged effects of immunotherapy are supported by the observation of delayed autoimmune toxicity from these agents even several months after they are discontinued, particularly with ipilimumab. Okay, so, digesting this and trying to translate it as best I can. So what are they saying here? Well, from what I gather, it seems like what they're saying is, they can't really justify the course of treatment that they chose. This kind of like Hail Mary approach. I think they make it explicitly clear, this combination therapy, this NAB paclitaxel, and this pembrolizumab, it seems like, as they describe it, like there's no prior evidence to show like this unique combination of therapy is effective. Yeah, sort of highlighted here. There is also no data demonstrating benefit for combining cytotoxic chemotherapy with immunotherapy. And so like this seems like it was a unique cocktail of a cancer treatment. You have stage 4 melanoma, it's spreading quickly, and you'll likely be dead soon. Patient up yours, woke more, yeah, if only it were that easy to treat cancer. If being woke, improved your cancer survival rate, maybe more people would go woke. Yeah, exactly. That is certainly a better way to phrase it, where it's like, hey, they just threw something at the wall, and it seemed like it stuck. And it seemed like it stuck in a pretty miraculous way. Which is great, right? Lucky for this person. And this goes to show, they are charting new waters, right? And this is why they published it. Right? This is one of the reasons why you publish case reports of like, hey, this is a very unique situation. Like this is literally one data point, right? At least at the time in 2017. And so like this is really like the exploratory nature of medical treatment, where it's like, hey, we can try this. This is literally not an evidence-based decision. But like at this point, you know, your stage 4 melanoma, you're getting worse. You don't qualify for any clinical trial, and so you literally have nothing to lose. And so, hey, we'll just try this. Like they literally just like, they didn't pull out of thin air. Like they obviously have, you know, cancer knowledge and cancer therapy knowledge. But I have no idea in terms of like what led them to like go with this particular unique combination. You know, that I wish I had that type of insight, because that is very curious to me. And so this presumably generates an avenue for future research, where it's like, you know, maybe this can be attempted in other situations, in you know, other kind of last-ditch effort situations, and then hopefully maybe with like a collection of data, you know, we can carry out, you know, your typical randomized placebo-controlled trial, and then get good quality data out of that, right? Because even though this is a case report, even though this is technically published, you know, quote-unquote scientific research, even though I would say this is not, this is like really on the outskirts of scientific research. But like, yeah, this is just, you know, an avenue for further exploration. So, in summary, this case report illustrates that cytotoxic chemotherapy may produce significant clinical benefit with acceptable side effects in patients that have progressed on combination immunotherapy, even in the setting of active symptoms and elevated LDH levels. This report supports the rationale to consider such treatments in appropriately selected patients. Further, in order to inform clinical decision-making, we believe that there is a need to systematically evaluate cytotoxic chemotherapies in patients previously treated with anti-PD-1, and potentially to compare the effects with and without continued immunotherapy. Such trials would be particularly relevant for patients without a BRAF mutation and or that are excluded from immunotherapy trials due to prior toxicities. So like, yeah, they are basically calling for more research and more controlled research, and specifically looking at, you know, these types of questions. But also, rewinding a bit, what they allude to earlier, also, what made this situation, another thing that made the situation unique, is not only like the unique combination of treatment that ended up being effective, but also, as they highlight, this patient tried, you know, a first-line treatment, as in they had their initial course of therapy, okay? And that initial course of therapy failed. And they sort of make it clear, or like they're asking the question, maybe this patient needed to fail these therapies in order for this new cocktail of therapies to be effective. Like this is a known thing, especially when it comes to the realm of like antibody therapies, where it's like past therapy can affect future therapy. Oh, this is Bill. I'll give them a shout out again. They were previously known as Bill Synthetic, but they have rebranded as Bill XOXO. They stream politics, but I think they're currently on a break, and also they don't save their VODs. Well, they stream politics, and I think horror games. Well, if I remember correctly. No, I do remember correctly. But like, yeah, as they allude to here, it may very well be the case that this patient needed to fail that first course of therapy in order for this next phase of therapy to be effective. I'm going to try, and this is like the best example that I can use, that I can sort of personally relate to. Oh, and Chutoy, welcome. Well, when I got my vaccine, it hurt my arm, and the doctor wouldn't even kiss my... Well, I have no doubt that, you know, you can take it. That you're a real man, Chutoy. And that a boo-boo will not hold you back from future vaccinations. Yes, they are on the Discord. I think they are... I know that they are on the Discord as Bill Synthetic. But let me just try to get an example of like how past therapy affect future therapies. And also hope you're doing well, Chutoy. As well as you, Myopic. One second. Trying to... Fine. Might take me too long. How many studies? Never mind. I don't want to bore everyone. But like, yeah. Summarizing, you know, past therapy can affect future therapy. And this is particularly true when it comes to antibody therapy. And especially antibody therapy that affects the immune system. Because so a lot of these antibodies, you know, yes, they appear to be effective, but like, so your body your body has antibodies themselves, and your body, okay, even though we're using antibodies as a therapy, okay, as, you know, hopefully an effective therapy, you know, your body doesn't want foreign antibodies injected into it. Okay, and so it's not uncommon, and this is like a known thing when it comes to antibody therapy, is that your body, if you introduce a foreign antibody into your own body, you as a human being will generate antibodies to that antibody, and you will potentially neutralize the therapy. This is one of the reasons why you can potentially become resistant to an antibody therapy. It's because your body says, hey, this is not one of my antibodies, and so I'm going to mount an immune response to this antibody. Checkmate indeed. Also, the nurse wouldn't even take a sample. Even when I said they had to do them, they kicked me out and said, sir, I've heard that one before. I've been away for more than a day, although the exact amount of... well, yeah, if you need sleep, take care of yourself. But, like, yeah, this wraps up the case report. Very cool. Very miraculous. I'm happy for Bill. Obviously happy for his friend. And, like, you know, this seems to be a pretty miraculous case report. Where it's like, you know, this last-ditch effort resulted in, like, a huge turnaround and really rapid, crazy recovery. So, moving on to the second topic. In the title of my stream, covering this paper of, like, do we have any evidence that, you know, the vaccine saved lives? Can we even come up with evidence that the vaccines, the COVID vaccines, have saved lives? That wouldn't surprise me, but I'm pretty familiar with most autoimmune disorders, and I can't think of one. I think maybe the closest would sort of be maybe lupus. But either way, that's a tangent. But you're probably right. There's probably some obscure autoimmune disorder that, like, as part of it, you just generate antibodies against your own antibodies. But, like, yeah, can you come up, you know, if people are surviving, right? How do you measure that? How do you determine that, like, a vaccine saved lives, right? Because you can't run. There's no time machine, as far as I know. You know, how do you come up with a control group? You know, I think it's super complicated, right? And, like, I think there's a reason why, you know, they're relying on mathematical modeling, because that's probably the best tool we have available, right? Like, how do you measure survival when, you know, someone is continuing to live? And that's the outcome that we want. That's difficult to test for. Sure, excess mortality went way up, but minimum mortality went way down in correlation. You're given all the classic arguments. So this study here was sent to me by fellow community member Bob Marley number 1 specifically. We're like, yeah, the global impact of the first year of COVID-19 vaccination, a mathematical modeling study. And I haven't, I've only, like, very briefly glossed through it. And I'm probably you're basically going to be seeing me in real time, sort of, like, digest this study in real time. But the one thing that did sort of catch my attention is who it's funded by. And so, even though, okay, potentially this study, based off of modeling data, okay, they're able to show that, you know, maybe the vaccines did save lives. But is that enough to convince the vaccine hesitant? Yeah, if you need sleep, myopic times, then take care of yourself and get some sleep. And, like, if I'm inducing sleep in you, then you should listen to your body and go to sleep. And I should maybe listen to that cue and be more interesting. But, like, yeah, you know, what type of evidence would the vaccine hesitant need in order to be convinced that the vaccines are effective, or that the vaccines save lives? Would it be evidence like this? Mathematical modeling? Probably not. No matter how, conclusive and rigorous it was. But another thing that I think, will stand out to the vaccine hesitant is who it's funded by. There's a number of funders listed here, but one of them is the Bill and Melinda Gates Foundation. And so it's like, you by default you can't trust it. That's pretty much I think will be sort of the instinctual response from those who are vaccine hesitant. Oh, and armed with my opinions, thanks so much for passing by. Much appreciated. Whether you say that unironically or not, I have no idea. But I have no doubt that would be, a legitimate response from some of the vaccine hesitant. And so it's like, yeah, I respect this evidence, I accept it. But I'm reasonably confident that this would not be enough to, convince anybody who's still on the fence, right? Like, if all of the sort of data released so far doesn't convince you, and like the data that we have released so far, like it's real life data involving human patients, as opposed to this is like a mathematical modeling study. And so it's like, I have kind of low expectations that this would be accepted in the vaccine hesitant community. I'm not sure it's about evidence, unfortunately. The deep well of cognizance and post-hoc... Yeah. I think we're on the same page there, Chutoy, unfortunately. I couldn't tell, actually. I have no idea whether you're saying that unironically or not. So, we're just going to get right into it. The first COVID-19 vaccine was delivered outside of a clinical trial setting on December 8, 2020. By December 8, 2021, 55.9% of the global population was estimated to have received at least one dose of a COVID-19 vaccine. Their use of decimal points, very weird to me. I don't think I've ever seen this before from The Lancet. Why is the decimal like right smack in the middle of the numbers? Whatever. 45.5% estimated to have received 2 doses, and 4.3% estimated to have received a booster dose. Despite the incredible speed with which COVID-19 vaccines were developed in 2020 and subsequently distributed during 2021, more than 3.5 million deaths due to COVID-19 have been reported globally since the first vaccine was administered. Understanding the global impact of vaccination on the course of the COVID-19 pandemic is challenging, given the heterogeneous access to vaccines coupled with different levels of transmission and ongoing non-pharmaceutical interventions across countries. In the early months of 2021, the impact of vaccination would have been minimal because of the delay in developing the infrastructure for a widespread vaccination campaign. The need for a delayed 2-dose regimen in some jurisdictions to ensure maximum protection, and the delay in the development of antibodies following vaccination. Additionally, as vaccine supply was constrained, most countries opted to prioritize vaccination in high-risk populations, including healthcare workers and older people. Such strategies would have generated direct protection, but would have had comparatively less impact on SARS-CoV-2 transmission. However, from mid-2021 onwards, those countries with access to plentiful vaccine supply opted for mass vaccination of the adult population, later including children, and subsequent boosting to maintain high levels of protection given the waning in vaccine efficacy and the emergence of new variants of concern. This approach has resulted in vast inequalities in global vaccine distribution. To reduce inequality, a fair allocation mechanism for COVID-19 vaccines was developed through the COVID-19 Vaccines Global Access (COVAX) facility, with a key target of achieving 20% vaccine coverage for the countries covered by its advance market commitment through COVAX secured doses by the end of 2021. WHO expanded this target by setting a global strategy to achieve 70% coverage in all countries by mid-2022, with an interim target of 40% coverage by the end of 2021. However, as a result of numerous challenges, particularly the constrained vaccine supply to COVAX, exacerbated by some countries obtaining a greater proportion of the global vaccine supply, pharmaceutical companies not meeting their contractual obligations to COVAX, and unpredictable delays in supply, including vaccines with brief expiry windows. These targets were not reached in many lower middle-income countries and low-income countries. Vaccine uptake has also been suboptimal in many countries because of vaccine hesitancy. This considerable heterogeneity in vaccination coverage has resulted in continued reliance on non-pharmaceutical interventions for pandemic management in some countries, but concomitantly enabled other nations to relax interventions as a route out of the pandemic. Quantifying the impact of vaccination is further challenged by the incomplete picture of the COVID-19 pandemic that is obtained from reported deaths. And so, like, this is something that, we have to recognize and grapple with, of, like, yes, we have the data from excess mortality. Like, we know that there are people dying directly from COVID, but it is, difficult to get good, high-quality data across the globe about the number of people dying that is directly linked to COVID, right? Because, we have comorbidities, and, like, it's not always easy determining cause of death. Like, I'm not a coroner or any sort of person to, determine cause of death, but I know that, like, for example, the best example that I can use is of, like, if someone who has, like, a blood clotting disorder of, like, they're a hemophiliac, and, like, they just their body struggles to form a blood clot, and, like, they're involved in a car crash, and, they experience some sort of, like, severe injury resulting in blood loss, and they pass away. Did that person pass away from, like, the car crash, or is it a result of hemophilia or the blood clotting disorder? Same thing if a person who has a severe compromised immune system and they get the flu, and they pass away from the flu. Is the flu the cause of death? Or is it, as a result of, like, their severely compromised immune system, and then the flu that is the cause of death? There's so many confounding variables. Yeah, totally, don't disagree with that. However, even in countries with quantifying the impact of vaccination is further challenged by the incomplete picture of the COVID-19 pandemic that is obtained from reported deaths. In many countries, vital registration systems are incomplete, and therefore only a fraction of deaths are routinely reported. However, even in countries with complete vital registration systems, it is difficult to accurately define the cause of death in individuals who present with multiple morbidities. Excess all-cause mortality, the difference between the observed and expected number of deaths in non-pandemic years, has therefore been used to quantify the impact of the COVID-19 pandemic. Necessary causes, sufficient causes, and exacerbating causes. Yeah. And I'm not going to say, like, I fully understand those distinctions because I'm not a coroner or I'm not a person who evaluates causes of death. But I have no doubt that that is where semantics are important. But I also know that sometimes, like, it's virtually impossible to say with confidence that, like, this is the one thing that caused death, right? Like, even when it comes to, like, we know this even from, like, court cases of, like, what exactly did cause, like, this victim's death. And you have, like, multiple experts testifying to, like, different things. Like, I think we kind of saw that a little bit with, like, the George Floyd case. For, like, for the trial of Derek Chauvin. Of, like, was it because, illicit drugs? Certain drugs were found in George Floyd's systems. Can't remember exactly what the combination was. But, like, that was, like, a confounding factor, right? But you also had the experience of, like, Derek Chauvin, pressing their knee into their neck. And so you have, like, the this complicated situation of, like, this person in distress, this person that has, certain substances in their body, and they're being subjected to, pretty much a torturous experience. And so, like, how do you pinpoint, like, what is the cause of death? And I think, even though expert testimony said that, like, pretty much, well, Derek Chauvin was found guilty. And so, like, we were able to say that with confidence, but there are clearly other complex cases where it's not as cut and dry. Still researching, but for now, I say I'm gender fluid. I might change it later until I have found what described me best. So if that journey made you less ignorant, then I'm glad to hear that. And if you identify as gender fluid, and that feels good to you, then go with that. And I fully support that decision. To believe evolution is true, it is necessary to believe natural selection, but natural selection is insufficient. If you believe in deep geological time, natural selection, and mutation, then those together are sufficient. Understanding Mendelian genetics would exacerbate, but is neither necessary nor sufficient to believe evolution. It contributes evidence. So I understand the example that you're trying to outline here. At least I think I do. And relating it to, like, these distinctions here of necessary causes, sufficient causes, and exacerbating causes. But I don't even know, and I would take your word for it, but, like, do even coroners, or, like, whatever the professionals who investigate causes of death, do they even use these terms? I don't even know. But I suspect not. Yeah, I'm not sure what coroners do either. So, although the exact contribution of COVID-19 to excess mortality is unknown, the strong temporal correlation observed globally between reported COVID-19 mortality and excess mortality provides evidence that excess mortality is an informative indicator of pandemic-related mortality. Robust vital registration systems do not exist in many parts of the world, with WHO estimating that 40% of global deaths that occurred in 2020 were unregistered, and therefore data on excess mortality are not available for every country. Model-based estimates have therefore been developed to obtain a more complete estimate of the pandemic to date. One set of estimates, produced by The Economist, uses a range of socioeconomic and epidemiological data to infer excess mortality. Although the precise estimates differ between research groups and WHO, they all suggest a substantially larger number of COVID-19 deaths than have been reported to date. So, there's a lot said. I think, to summarize, it boils down to, based off of all of the excess mortality, the good quality excess mortality data that we have, generally speaking, of all the analyses that we've carried out, it's consistently found that COVID-19 deaths are underreported, as in, I've covered this on a previous stream. But when you looked at excess mortality in, for example, India, and they really sort of went back into the data to really try and determine, as best as possible, the exact number of COVID-19 deaths. It turns out like the number of COVID-19 deaths in India was, at the time, underreported. And it seems like that trend holds true across pretty much throughout all of the data. Like, generally speaking, it seems like the rule of thumb is COVID-19 deaths are significantly underreported. This is more relating to analysis of, yeah, that's fair. Resident sleeper, the fact is that the jab is causing heart attacks in young men, and I don't disagree that Fauci is cringe. So who is forcing you at this point to get a jab? And if it's resident sleeper, that you're totally entitled to that opinion. Like, I have no delusions that I'm entertaining or informative to every single person out there, or even one. But like, and if you want to provide actual data, but maybe I shouldn't expect that given your username, where it's like, yeah, if you just want to come with your opinion, that's fair and that's fine. But I think there are clear flaws in just only relying on opinions. Yeah, so I don't know Mark Lobliner, but I have no problem saying that I probably know way more about fitness than they do. Unless they have a PhD in some sort of like health field, in kinesiology, athletic therapy. I have no problem saying that Mark Lobliner is probably like a pretty poor fitness expert. And most people in the fitness industry are pretty ill-informed. As someone who was a personal trainer, and I have way more scientific training than like the overwhelming majority of fitness experts out there, I would bet a fair amount of money that Mark Lobliner, unless like a medical doctor as well, probably has very little idea of what they're talking about when it comes to either COVID-19, vaccination, or just health in general. Yeah. And I don't see what soy has to do with it. And if I'm cringe, that's fine. I have no problem being cringe. Yeah, so now I can't help but think that, you're being sarcastic. Like, there's absolutely no way that I can take you seriously anymore. And I'm almost certain that you're just like, whatever, trolling me. If you say like Rich Piana is a natural bodybuilding legend. Now, whatever. The ruse is up, so to speak. Nobody's forcing you to get vaccination. Yeah, exactly. I think most countries have pretty much moved away from like vaccine mandates. And like, yeah, there's totally an ethical question when it comes to the vaccination. Yeah, they're so natural that they passed away from mysterious unexplained causes. Now I know you're just joking with me. We aim to quantify the global impact of the first year of COVID-19 vaccination and estimate the number of deaths from COVID-19 averted in 185 countries and territories, both from the direct protection of vaccinated individuals and from the indirect protection of all individuals living in vaccinated environments due to the reduction in risk of infection. Additionally, we aim to quantify the impact that a more equitable global vaccination campaign meeting the vaccination target set by COVAX of 20% vaccination coverage of the eligible population by the end of 2021 could have had in COVAX AMC countries. We also aim to quantify the impact of achieving the WHO target of 40% coverage by the end of 2021 in all countries. So, what was their methodology? Should I even go through the methodology? Absolutely. I have no problem doing a fitness advice stream. I would love to do that. 100%. That's a passion of mine. Science is a passion of mine. If that's what you want, I will schedule it. I will organize it. I would ask you, is there something specific that you're looking for? Is there like particular questions that you want answered? Do you just want a Q&A? If you want to provide me, if you want to join the Discord and provide me with like a list of questions or things that you want me to cover, I'd be more than happy to cover them, or do my best to cover them. Because I love talking about fitness, and especially if you want me to bring in science, fitness, then you know. You're speaking my language. So, should I even go through the methodology? Because this is mathematical modeling. And I have no problem saying that I am nowhere close to an expert in mathematical modeling. And I'm in no position to like dissect the methodology. Maybe just read the first paragraph and kind of see if I can understand what it is they're doing. For this mathematical modeling study, we used a previously published COVID-19 transmission model. Okay. So, you know, in their own modeling, they used another model and fitting framework to obtain profiles of the COVID-19 pandemic in each country and thus estimate the counterfactual scenario in which vaccines are not delivered. Briefly, the model is a population-based, age-structured, susceptible, exposed, infectious, recovered, susceptible model. Okay, yeah. That's a lot of whatever gibberish to me. I understand these individual words, and I more or less get the gist of it. But obviously, I have no real detailed understanding of what their model is doing. Which explicitly captures disease severity, passage through different indicated healthcare levels, and the rollout of vaccination. We incorporated country-level data on demography, age-based mixing patterns, and healthcare capacity. We fit the model to officially reported COVID-19 deaths in each country, resulting in an inferred time-varying level of transmission, RT, denoting the mean number of secondary infections in the absence of both infection-induced and vaccine-derived immunity, by fitting directly to mortality. We indirectly captured the impact that non-pharmaceutical interventions have had over the course of the COVID-19 pandemic. Okay, so basically they're doing a lot of modeling, and there's a lot of assumptions, and you know, they're working with prior data, but like, yeah, this is, as made explicitly clear, this is a mathematical model, and I'm not qualified to assess their mathematical model, and so me just reading the methodology is useless. I'm in no position to like get across any sort of like understanding. And yeah, if you want to join the Discord, that should hopefully provide a link to it. And well, I know what they're doing here in terms of this software. R is, you know, a coding language, very popular, open source. I have attempted to teach myself R, but like, yeah, it's basically very often used in data science to, you know, analyze data, generate pretty graphs, pretty figures, etc., etc. And like going back to like the funders of the study, you know, even though, you know, yes, Bill and Melinda Gates Foundation is part of the funders of this study. And so many people would say that this is a bias, right? And I think especially those who are the vaccine hesitant, they would point to this saying, hey, this is a reason why you can't trust it. But also at the same time, you know, studies also explicitly say this, right? The sponsor of the study had no role in study design, data collection, data analysis, data interpretation, or writing of the report. But I have no doubt that despite this, you know, this is not enough to like soothe the vaccine hesitant, right? They would still say that, you know, the fact that the Bill and Melinda Gates Foundation is one of the sponsors of this study, that means that it's automatically biased. And that, you know, this is untrustworthy. That basically this portion is probably unbelievable. And that, you know, they're probably lying here when they say this. So, should I go through the results? I'm not going to read the results. That's probably not necessary. Maybe try to understand some of these figures here. I'm probably just going to jump right to the discussion. So, I wish I can zoom in more, but this is like the max zoom that this allows me to do. So, global COVID-19 deaths averted due to vaccination based on excess mortality. So you have model fit to excess mortality. So in gray, the gray bars, that is presumably the real excess mortality. And then you have, okay, they're doing some model fitting. And so they're basically kind of like doing a difference. As in like, here's the reality. This is kind of like what we predicted, potentially like in the absence of vaccination, essentially in a nutshell. And so it's kind of like the difference between like, you know, the blue and the gray to an extent. And then you have, okay, they're stratifying it based off of kind of like socioeconomic status or countries. High income, upper, lower, and low income countries. Which makes sense. Deaths averted per 100. Okay, so they're doing a rate as well. So, you know, clearly some pretty complex analysis, right? This is a global analysis. Using modeling data, or rather, using data and attempting to model globally. And so basically, the darker the red, the more deaths averted. And so, no surprise, generally speaking, developed countries, United States, Canada, many parts of Europe, Australia, you have the deepest red, and so the most deaths averted because they had, you know, the most aggressive, well, they had access to vaccine, period, right? It's, you know, it's the developed countries that were in the economic position to purchase the vaccine ahead of all of the other countries, resulting in, you know, pretty significant vaccine inequality. So, we're just going to jump right to the discussion, summarize their findings, right? This is where, you know, I have to rely on what these experts are saying, you know? Sure, could I have read the entire methodology? Yeah. But could I dissect it? You know, could I poke holes in it? Could I point to flaws with any degree of confidence? The answer is no. I am just a biochemist. I am not a data scientist. I'm not a statistician. I am not an epidemiologist. I'm assuming some sort of epidemiologist or public health expert was involved in this. Let's see who was involved. You have... Where are the affiliations? Super curious. Sometimes at the end, yes. Well, this is pretty disappointing to me. Oh, Wick, thank you so much for passing by. And definitely check out Death of Certainty's channel. They do great content, host great panels, do a great call-in show. And as a bonus, you know, this is also also shameless self-promotion. They've interviewed me. Well, it's not super disappointing. I was just saying, like, so I'm going through this study. This is a study attempting to kind of like show how many lives were saved by the first year of the COVID-19 vaccination campaign. And what I was pointing out is that, you know, I am not an expert in COVID-19. I'm also not an expert in epidemiology. And so I was pretty much trying to point out that, you know, even though I'm reading this study, I did not read the methodology because I'm not qualified to, like, dissect the methodology. And so I was trying to figure out who exactly was involved in this study, and what their affiliations are. Like, what university department are they coming from? As in, like, this Oliver J. Watson, I want to know, are they an epidemiologist, or what type of public health expert? Because that's typically listed as in, like, sort of shameless self-promotion to a certain extent. You know, me, if you look at some of my research, it's not ambiguous where I'm coming from. You have my name, you have this this superscript A, and this A corresponds to the Department of Chemistry and Biochemistry. And so at the very least, you know, hopefully, or have some confidence that I'm a chemist or biochemist. And so I was trying to figure out who are all these people? Where are they coming from? Aside from, yes, they come from Imperial College London, but, like, what department? I'm curious about that. And so I was kind of, like, let down. Like, why are you not doing this kind of, like, basic thing here that I'm used to seeing in every other scientific article? But maybe I'm just not looking hard enough. I don't know. So we're just going to wrap up this study by reading the discussion. And so, do they come to the conclusion of how many lives were saved from the first year of the COVID-19 vaccination campaign, the global COVID-19 vaccination campaign? The high individual level protection against severe disease and mortality due to COVID-19, as well as the population level benefit afforded by mild protection against SARS-CoV-2 infection, conferred by vaccination, has fundamentally altered the course of the COVID-19 pandemic. Directly measuring the impact of vaccination programs on COVID-19 mortality is not possible, as the counterfactual, that is, without vaccinations, cannot be observed. Mathematical models are a valuable tool for quantifying the impact of vaccination campaigns on epidemic dynamics. We evaluated the impact of the first year of COVID-19 vaccination, revealing how vaccinations have more than halved the potential global death toll due to COVID-19, with an estimated 19.8 million deaths from COVID-19 averted as a result of vaccination, based on excess mortality estimates of the impact of the pandemic. So, it seems like they're saying, based off of their analysis, based off of their modeling, during the first year of the global COVID-19 vaccination campaign, there were roughly, or an estimated, 20 million deaths prevented from the vaccines, which can't even. I've lost track of the data. How many deaths are we at currently from COVID-19 globally? I would imagine we're at, I don't know, approaching 2 million. World. So I'm way off. Yeah, this is the world. Over 500 million cases. Over 6 million deaths. And so basically, potentially based off of, this data and this study, more than 3 times this number of deaths have potentially been prevented. We can't say with absolute certainty, right? Yeah, fair enough. So like, that's a lot. To me, that's pretty significant. That is more than half, or approximately half the entire population of Canada. So I think that's pretty significant. These reductions were concentrated in high-income countries that relied on their vaccination programs to relax interventions and allow SARS-CoV-2 transmission to increase as they moved into a new stage of the pandemic. And like, yeah, this is, not surprising. As I mentioned earlier, it's the high-income countries that were in the, financial position or the economic position to, purchase these vaccines. In low-income countries, particularly countries that did not reach the 20% target set out by COVAX, vaccine impact was substantially lower, with vaccine impact estimated to have been almost double if the targets had been reached. If the 40% target per country from WHO had been met, we estimated a further increase in deaths averted, mainly focused in lower middle-income countries and low-income countries. And yeah, they're basically speaking about this figure here, where, based off of their color scheme, the deeper the red, the more deaths prevented. And you see, if you look at the continent of Africa, they're pretty much like at the lightest shade of red. And so there's like the least number of deaths prevented because, like, they basically had very little or poor access to vaccines, unfortunately. Where was I? Lost my place. A limitation of our assessment of the COVAX and WHO targets is the time frame of our analysis. Oh yeah, and that's another thing to keep in mind, right? This is just the first year of the vaccination campaign. And so I'm almost 100% sure we are pretty much moving into the second year of the vaccination campaign. We're approaching that. And so potentially even more, significantly more than 20 million deaths have been prevented. Maybe approaching, 30, 40 million. As these targets were set to be reached by the end of 2021, whereas our modeling endpoint was December 8, 2021. So, like, yeah, we're, halfway through, a little bit more than halfway through 2022. So, like, this analysis is essentially like 6 or 7 months old, to align with 1 year since the start of public vaccination. Hence, some countries might have moved closer to achieving the targets or achieve them by the end of the year. However, any recent vaccination drives would have had consequently negligible impact given the delay in developing protection and insufficient impact on COVID-19 dynamics. Deriving estimates of vaccine impact is heavily dependent on the counterfactual scenario chosen. In our counterfactual, we assumed the same time-varying models of SARS-CoV-2 transmission as estimated in our model fits. Consequently, the largest impact was observed in countries that delivered the most vaccinations to date and simultaneously relaxed interventions, allowing SARS-CoV-2 transmission to increase. However, several countries with slower vaccination rollout, as well as countries adopting a zero COVID strategy, maintained stronger interventions to suppress transmission and thus observed smaller impacts of their vaccination programs as a result. As these countries start to reopen, we predict that vaccine impact estimates would increase in line with increasing levels of SARS-CoV-2 transmission. And like, given the fact that their model basically runs from the end of 2020 to basically December 2020 to December 2021, I speculate, I don't know for sure, but I suspect that their modeling doesn't take into account the Omicron surge. Because if I remember correctly, basically like the peak of the Omicron surge kind of happened like from like November to like February of this year. At least in my area in Canada or Quebec, like our peak of like the Omicron variant was like December to January. And so potentially like this data doesn't take that into account. And I think there was a pretty clear surge in deaths as a result of the Omicron variant. And so maybe, this is speculation, but maybe this is like an underestimation of the deaths prevented from the vaccination campaign. But that's just me thinking out loud. I can't say that with any confidence. Under ascertainment of COVID-19 mortality is a known issue that has hindered our understanding of the pandemic. In this analysis, we consequently focused on fitting to all-cause excess mortality, which provides a more complete description of the pandemic. However, even when relying on model fits based on reported COVID-19 deaths, we estimated that more than 14 million deaths were averted by COVID-19 vaccination. The discrepancy between vaccine impact estimates based on excess mortality and COVID-19 deaths was concentrated in settings with lower death registration and certification. This substantial discrepancy underpins the crucial need for continued investment in civil registration and vital statistics to prevent biases in mortality reporting, further minimizing the perceived impact and necessity of vaccination settings with lower reporting of deaths. And so they're basically calling for, so I think it's pretty clear to most people that across countries, even when it comes to reporting on cases, the data collection or the ability to collect data and report data is not equal across all countries across the world. Generally speaking, in developed countries, we have a greater capacity to not only like track data, but to analyze data. Use like the simplest example when it comes to cases, to reporting COVID cases. Generally speaking, developed countries were better at reporting COVID case numbers because they had like the ability to implement mass testing centers, and they had a greater capacity to run these PCR tests, and to run all the other sort of rapid tests for COVID-19, as opposed to developing countries. They have much less ability for that type of testing capacity, and so like even when it comes to case numbers, it was hard to trust, or like you had to understand that probably when it comes to reporting cases in developing countries, it's almost certainly a huge underreporting, as opposed to in developed countries, there's more confidence that like the cases reported, yes, it's usually an underestimation, but it tracks closer to the reality. In countries with more complete reporting systems, our estimates were broadly comparable to other endeavors focused on officially reported COVID-19 deaths and on understanding the direct impact of vaccination on people older than 60 years in Europe. We identified one study that estimated both the indirect and direct impact of vaccination, which again yielded estimates for vaccine impact in the USA that were similar to our impact estimates based on reported COVID-19 deaths. In our effort to provide impact estimates globally, we introduced various assumptions into our model. And so it's like, this is where you have to keep in mind. They are doing some modeling. And as with any modeling, you have to use assumptions. And this is where, you have to take the number that they're reporting or take it in context of like, yes, they are estimating that approximately 20 million deaths were prevented as a result of the first year of the COVID-19 vaccination campaign. But they are transparent that they are using modeling and that they are working on some assumptions. And maybe some assumptions are flawed. Hard to say. But just recognizing that might be the case. That doesn't mean that their conclusions are false. That doesn't mean that the findings from this study can be ignored. It's just that, this is not 100% conclusive proof. We were hindered because, I'm repeating myself, but recognize that this is a peer-reviewed study. This is a study published in The Lancet Infectious Diseases. And so this is a peer-reviewed scientific medical publication. And so, the authors of this paper, they had to submit this to the journal. It had to go through peer review. And the fact that it was published, that means that it passed peer review. And so a few experts read it. They potentially criticized it. And so it was up to the rigors of the journal. That's why I say it can't just be discounted, because the peer reviewers, they accepted it. They accepted it for publication. So we were hindered by the global disparities in SARS-CoV-2 genomic surveillance and the absence of detailed vaccination data for the majority of countries. Consequently, key model inputs had to be created from working assumptions on which vaccines were delivered, how they were delivered, and when new variants of concern spread worldwide. So they're being transparent that, there were quite a few question marks or unknowns. But they just went with kind of like the best available assumption at the time. We also assumed that the relationship between age and what does IFR stand? Can't remember. To infection fatality ratio. Right. Yeah. We also assumed that the relationship between age and infection fatality ratio was the same for each country. And maybe that was not a correct assumption. I'm in no position to say, but they're being transparent about what it is that they're doing. These assumptions would have affected our estimates of deaths averted, with sensitivity analyses showing that higher IFRs will increase the number of deaths that could be averted by vaccination. Our impact estimates were also limited by the inherent uncertainty in model-based estimates of excess mortality. These estimates are likely to have underestimated or overestimated COVID-19 death tolls in many countries, notably our model fits were unable to recreate excess mortality death tolls in recent epidemic waves in Iraq and Sudan because of the depletion of the susceptible population. These discrepancies could have been due to multiple reasons, including overestimated excess mortality, proportions of excess mortality not due to COVID-19, higher infection fatality rates by age in low-income settings than those estimated from high-income countries, and lower vaccine effectiveness than assumed in our framework. Last, our impact estimates were dependent on the assumed degree of immunoscape that each variant of concern exhibits. So, it looks like in their discussion, in wrapping up their findings, they're really kind of like being transparent about all the assumptions that they're making and all the potential kind of drawbacks of their analysis or potential criticisms of their own analysis. If immunoscape was higher than we assumed, more of the population would have been susceptible to reinfection, and consequently, more deaths from COVID-19 could have been averted by vaccination. And so, again, they're being transparent of the fact that they're making a lot of assumptions. But this is me thinking out loud, but I'm reasonably sure that, the assumptions that they made were probably pretty conservative. As in the assumptions that they went with probably resulted in that 20 million deaths prevented being an underestimation in reality. Second. Something has gone amiss. OBS. Just try and fix it. Seems to be fine now. More broadly, our estimates should be considered in light of the considerable uncertainty inherent in estimating vaccine impact. Uncertainty in the true death toll of the pandemic, the circulating variants of concern and their immunological phenotypes, and the vaccines themselves administered in many countries vastly complicate efforts to derive accurate estimates of the impact of COVID-19 vaccine. However, the results of this analysis still provide a comprehensive and thorough assessment of the impact of COVID-19 vaccination, revealing the substantial impact that vaccines have had and the millions of lives that are likely to have been saved during the first year of vaccination. Despite this, more lives could have been saved if vaccines had been distributed more rapidly to many parts of the world, and if vaccine uptake could have been strengthened worldwide. Reaching vaccination coverage targets and improving vaccine coverage globally is dependent on multiple factors, not solely dependent on improving vaccine donations. Vaccine intellectual property needs to be shared more quickly in the future, with more open technology and knowledge transfer surrounding vaccine production and allocation. Vaccine distribution and delivery infrastructure also needs to be scaled up worldwide and misinformation combated to improve vaccine demand. Improvements must be made in all these areas to reach current vaccine targets and help ensure that vaccines are more equitably distributed in the future. Okay, so there's a lot, in my mind, a lot to digest and unpack there. So first things first, they are kind of like explicitly clear, or pretty explicit in my mind. So they're not, I guess they're not going as far as me in saying, hey, let's just abolish all intellectual property. They're just saying, hey, vaccine intellectual property needs to be shared more quickly. Which, super interesting to me, right? Well, sort of. This is not surprising to me, because, well, I'm used to reading scientific articles, but, they are giving prescriptive recommendations in the last paragraph of this study, right? They're saying what should happen, okay? they are saying this is the direction that we should move towards. Where it's like, hey, combating vaccine misinformation, sharing of vaccine intellectual property, more open technology, whatever that means, right? They're kind of like, in my mind, they're using ambiguous language, to kind of like not appear to be political. Instead of saying, hey, abolish intellectual property laws, just say vaccine intellectual property needs to be shared more quickly. And you need to have knowledge transfer, as opposed to like removing legislation that prevents people from either sharing knowledge, taking knowledge, gaining knowledge. But at the end of the day, they are still making prescriptive statements, right? And I want to highlight this because many people, even just yesterday, sort of getting into it with someone in chat, where it's like, hey, science doesn't deal with prescriptions. Science doesn't make prescriptive statements. You can't generate an ought from an is. They are being very explicit, at least in my mind, they're being very explicit in making prescriptive statements of like, hey, pretty much more sharing of knowledge. At the very least, we have to do something about intellectual property and sharing of knowledge and sharing of technology. Those are pretty prescriptive statements in my mind. Maybe I'm wrong, but to me, these are pretty clear prescriptions. And so for someone to say like, oh, science doesn't deal with prescriptions and science can't make prescriptive statements, I strongly push back against that. Unless you're going to say like, hey, who's to say that we shouldn't share information that would result in the prevention of more deaths in the future, in the prevention of 30 million deaths, 40 million. Who's to say that preventing deaths is a good thing, right? It's just taken as a given that is the direction that we want to go in. As in taking that 20 million deaths prevented as a good thing. Well, if we want to even do better in the future, these are some of the prescriptions that these experts would recommend. Again, it's taken as a given that we should improve upon the 20 million deaths prevented. And no one is saying, oh, well, 20 million deaths prevented, that's just description of reality. And who is to say that we should improve upon that, or that we should do better? To me, that is obvious, and if you want to call that into question, well then, I would say we're just not living in the same realities. So that wraps up this study, which I think is pretty cool, and super informative. And I'm grateful that Bob Marley shared it with me. They share really great research on a regular basis. And, again, I want to make it explicitly clear. This is a modeling study. Yes, but that doesn't mean that, again, you can discount its findings, or that there's this huge giant grain of salt associated with this study. But you still have to take its findings seriously, because it's published in a medical journal, and The Lancet is, generally speaking, a highly respected medical journal. It has a pretty good reputation for publishing high quality scientific and medical research. And so the fact that this was published in that journal, that counts for something. And, I would say it would be unfair to this study to just brush it off, just based on the fact that it's a mathematical modeling study. All right. So, those were the two things that I wanted to make a point in covering: that cancer case study, and that vaccination, that pretty much COVID study. And I didn't really have anything else planned. Oh no, actually that's not true. That's a lie. I also had this planned, or this article brought up. Bullying in science. Published a little over a week ago, or no, less than a week ago. And I want to cover this because, well, I'm in science and I'm a scientist. And also, as much as I love science, as much as I have a passion for it, at least, science at its core, driven by curiosity, driven by a search for truth, as opposed to, how science is actually in practice, in reality, at academic institutions or at private institutions. There's the human element. There's also the institutional element. It's no longer, whatever, Newton doing physics experiments in his home or in his backyard. It's people at institutions doing research, governed by institutions. And so there's a dark side, at least in my mind, in my opinion, a dark side of science. In my mind, it's leaning more towards, more dark than light. Although my opinion on that varies day to day. But especially when it comes to academia, there is totally, in my experience, and to my knowledge, based off of what I read about, and I read pretty extensively, there is totally a toxic culture in academia, particularly in science academia, largely driven by egos, faculty members that have egos, that they have a strong desire to basically pursue status as opposed to science. Pursue a nice CV or resume as opposed to science. Pursue prestige publishing as opposed to, science and answering questions. And what do I mean by prestige publishing? As in publishing in only those respected journals, those high impact journals. The Nature journal, the Science journal, etc., etc. Where it's like all they care about is publishing in those particular scientific journals. So, bullying in science. Largest ever national survey reveals bleak reality. Swedish study of the culture in academic workplaces suggests that women and PhD students are most likely to be bullied. 1 in 15 people studying or working at Swedish universities has experienced bullying over the past year, according to the largest ever nationwide survey of academic workplace culture. The results, which included responses from people at all of Sweden's 38 higher education institutions, reveal that women and young researchers are the worst affected, with 1 in 7 female PhD students saying that they had been bullied over the past 12 months, so greater than 10%. Similar patterns are likely to be seen in other countries with comparable research systems, such as the United Kingdom or United States, says Matthew Martin, a researcher at West Virginia University in Morgantown who studies bullying. He adds that in general, women are more often the target of bullying and sexual harassment than men. So let's see if we can attempt to understand this infographic. Bullying in academia, a survey of 39,000 students and employees across Swedish universities suggests that women, yes, more likely. So have you been exposed to bullying at your workplace during the past 12 months? Oh, I see. 9% of men said yes, 14% of women of the employees cohort. And then when you look at PhD students, same 9% of men, but 15% of women had experienced, and that's just in 1 year, right? If you extrapolate or if you extend the timeline to 2 years or 3 years or 5 years, or if you just ask, based off of all your time in academia, have you experienced bullying? These percentages would probably or almost certainly be larger. Bullying and harassment in science have come under increasing scrutiny in recent years because of the wider public awareness campaign, such as the global Me Too movement, through which huge numbers of women spoke up about their experiences of sexual harassment. Research funders are also placing a greater emphasis on cultivating workplace cultures that deter such behaviors through introduction of official anti-bullying policies. Since 2018, at least 2 high-profile researchers in Europe have had their funding withdrawn after investigations by their institutions found evidence of bullying. Nationwide survey to get a handle on the prevalence of bullying and sexual harassment at Swedish universities. A group of researchers sent a survey to a sample of university students and employees to ask about their experiences. The team, led by Kristina Björklund, who studies bullying at the Karolinska Institute in Solna, Sweden, received almost 39,000 responses between May and July 2021. A report outlining the findings was published in May. It is the largest survey of its kind globally, says Fredrik Bondestam, a researcher in gender-based violence at the University of Gothenburg in Sweden, who sat on the steering board of the study and helped design the research. Across all staff and students, 7% of respondents said that they had experienced bullying over the past 12 months, rising to 14% for female employees and 15% for female PhD students. See bullying in academia. That infographic. The proportions of affected researchers and administrative staff members were 12% and 10% respectively. There was no breakdown by gender for these groups. Rates of bullying in Sweden across the entire working population are around 10%. The survey took place when many universities encouraged employees to work from home because of the COVID-19 pandemic, so the researchers also asked about cyberbullying. Around 5% of respondents, or about 1 in 20, or exactly 1 in 20, said that they had experienced work-related bullying on social media, by email, or in text messages. Of the entire group, 4% of respondents said that they had experienced sexual harassment over the past year, with male university employees and male PhD students reporting such experiences at half that rate. Björklund says that among all working people in Sweden, the rate of sexual harassment is about 3%, according to surveys. Around half of those who experienced sexual harassment in academia said that they had told someone about their experiences, but just 12% reported the behavior through formal channels. It seems like only a minority actually reported, as they say, formal channels, the appropriate authorities. Interrupted and ignored. The researchers also asked about how often respondents had experienced types of microaggression, such as being interrupted or spoken over, ignored, or shouted at, that, if left unchecked, can lead to a working environment in which bullying and harassment are tolerated. More than 95% of respondents said that they had never been shouted at or sworn at, but 50% said that they had experienced situations in which their contributions or opinions were not given attention. 1/5 said that they were often or sometimes interrupted or spoken over. And that's an interesting stat. Second. I want to focus on sort of the shouted at. Sworn at, I'm not necessarily less concerned. The shouted at one sort of, I guess, relates more to me. And it's something that I observe pretty frequently And maybe that's just a testament to my department or my experiences in academia, and that's just anecdotal, and that's just my unique experience. But you know, I don't, I would not have estimated that, you know, the overwhelming majority of science academics would have said that they had never been shouted at. I actually, you know, if I were to, before reading this, I probably would have put it at like, kind of like the opposite. Almost like the vast majority have been shouted at, as opposed to never. But again, maybe that's just, you know, my unique experience. Not that I experience being shouted at personally on a regular basis, but it's more like something that I have observed pretty regularly. Being observed happen to other scientists, fellow scientists, where they complain about, you know, them receiving that treatment, either from, you know, potentially not colleagues, but, you know, superiors, other higher level faculty members. You know, it's not necessarily unheard of, or like, you know, I know of students who have been brought to tears because, you know, their boss essentially, you know, shouted at them and were, you know, basically verbally assaulting them. And so it's like, yeah, this 95% never been shouted at is pretty surprising to me. But hey, you know, if this is actually the reality, then that's a good thing, right? Problematic behavior. During the past 12 months, have any of your managers, colleagues, teachers, supervisors, or fellow students done any of the following? Interrupted, pay little attention, hostile look, stares, or sneers. Made jokes at your expense. Sort of like the passive aggressive like quips or comments. You know, maybe making fun of your competence, or questioning your competence, or questioning your intelligence, or questioning your ability to do science. Again, this seems based off of this, it seems to be a minority experience, as opposed to that doesn't track to what I observe around me. These incivilities matter, says Bjorklund. If you are interrupted all the time, what will happen to your opinions? We can see that if you have a good, inclusive work environment with support, it is related to higher performance. You will get more research money and write more publications. Before the release of the survey results, there were limited large-scale data on the prevalence of bullying and sexual harassment in the higher education system of any country. In January, the government department responsible for science in Ireland published the results of a nationwide survey on sexual harassment sent to all university employees and students, which garnered around 11,500 responses. It found that almost 1/4 of staff members had experienced sexualized comments, and 1/3 had been the target of sexist remarks. The European Union has also conducted a large study to help policymakers to understand the prevalence of sexual harassment and gender-based violence in universities and research organizations, on which it will report later this year. Bondestam says that the Swedish team invited responses from a large number of university employees and students to ensure that the study had representative data to ward off criticism from people who do not think that these problems exist at universities. Wanted to be able to say, this is the data, don't mess with the figures. And it's good that they're making an effort to kind of like combat this, or like to ward off criticism. You know, it seems like they want to make an effort. Well, I think every scientist, or most scientists, want to make an effort to generate good, high quality data that, you know, won't be called into question, but also recognize that every study, every piece of data that comes out from science can be criticized. There is no such thing as perfect science. There is no such thing as a perfect publication. And you can poke holes and criticize every study that comes out. Me as a biochemist, depending on, the biochemistry publication, but I can poke holes in probably the majority, or a significant proportion of biochemistry scientific publications. But that doesn't mean that I would discount them. That doesn't mean that I would ignore them or say that the results are invalid, and that I can just brush them aside. Criticism or flaws doesn't mean you can ignore. I repeat that often, but that's a point that I feel I can't emphasize enough. I'm probably gonna continue to save this. So what else? So yes, there were a few things that I wanted to watch, or I had a playlist for. This Jubilee video. Do white people experience racism? And also this gives me a chance to recover my voice, since I've been speaking for over 2 hours now.
Middle Ground is a social experiment that brings humans with opposing beliefs or experiences together. These discussions may contain viewpoints that are the result of misinformation. Remember to seek out experts and to be critical of your own biases while forming an opinion. Please see the humanity in each participant, and as always, we encourage empathy.
Two things can be true. You can have had a very hard time. Privilege is not just limited to white people, but to say white privilege doesn't exist from a historical context, to me, is respectfully absurd.
Yeah, and I would tend to agree. I don't think, I think basically racism, anybody as part of humanity can experience racism. That's pretty much my stance at this point, but I could be wrong.
Step forward if you agree with the prompt. White people also experience racism.
I think racism is definitely not a one race against the other. It goes all ways. It doesn't matter if you're white, if you're black, if you're Asian, it doesn't matter. You could experience racism no matter what color your skin is.
I think that people have a propensity to kind of have an aversion towards what's different from them. I've been called a cracker before. I've been told I was going to get beaten up because I was white. I would argue that on a systemic level, white people don't experience racism the same way a lot of other races experience racism. But I would say on an...
Well, yeah, I would agree with that sentiment. Almost certainly at an individual level, virtually every human being on the planet can experience racism or discrimination, I guess would be maybe the more appropriate or universal term. But I also think it's fair to say that, like, yeah, at institutional level, at least in the United States or in certain developed countries, it's totally different.
Individual level, any group is capable of being racist towards another group as well.
So the argument against this position frequently is that racism is a system, not a sentiment in the United States. And I agree with that really strongly, but at the same time I'm Jewish and racially white and have definitely experienced racism, discrimination. The paradox is that most of that racism is coming from white people or European society, white nationalism, etc. that's directed at Jews. So I'm Dane and I'm Jewish. I'm proud of being Jewish and being connected to an ancient religion and culture, but I'm not proud to be white, I would say. White privilege, I think, is an aspect of American society. I think it exists. When I go to a job interview, I don't have to worry about my hairstyle or the way I normally speak or my name. And that's something perhaps a black person would have to worry about.
Can the disagreeer step forward?
So I just want to say that I want to validate everyone's individual experiences. I do also believe that white people experience bias, prejudice, but the reason I did not step forward is because, by definition, racism is tied to power and economics. You talked about systemic discrimination. I don't feel white people experience racism by definition and by actual concept.
What is the definition of racism and who wrote that definition?
In the late 1500s, early 1600s, there was slavery. They started bringing over slaves, but there was really no concept of classifying people in terms of race. It's just we're bringing these people over and they're slaves. What ended up happening is some of the slave owners who were white started mixing with some of the slaves. And now here you have these black people that look like the people that are owning things. So they're like, whoa, 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 whoa. The theory of race was formed to classify a group of people who would be lesser than and have less economic power, and this would be imposed against them for hundreds of years. So that has not been the white experience in this country, but it does not invalidate the things that white people experience. It's just not racism by definition. Is it prejudice? Is it bias? Is it wrong? Yes.
Mine is simple. If one person treats another person differently because of the color of their skin, to me, that's racism. I will tell you that I was stopped by the police plenty of times when I was a young man. And I will also tell you that I then decided to spend 35 years as a policeman. I'll tell you that I stopped lots of kids coming home from school. Depending on who it was that I stopped, the first thing out of their mouth would be, "You only stopped me because I'm black." And I would say, "You're driving a sports car with a back window that's this big, I can't see who's driving, and I stopped you because you're doing 95 and a 55. I had no idea who I was pulling over until I stopped you." Now, if I treat you differently because you're black, then I'm a racist. But if I write you the same ticket that I was going to write you before I knew who was behind the wheel, I'm not.
So I'm glad you used that example, and I want to commend you for your service for our country. But I do want to say, because I've actually taught classes for the LAPD and for their cadets about these issues. But what I can say, which is a statistic, and which is also a fact, is that 60% of our prison population is African American.
Different issue.
Yes, but let me finish, please. Is African American males, right? When you go into a system and you are kept in that system and you're cycled through probation and...
Yes, I've covered this before on stream. Scientific publications showing, the mass incarceration, particularly of Black people in America, and all the negative results from that, particularly at a family level, not only just an individual level.
There is a systematic sequence of oppression. That's not happening to white males. So it's bigger than just the stop itself. It's the system. My name is Sierra. I'm an actor, a speaker, and a human rights activist. I'm very proud to be African American, to be Black. The challenges that come with being Black, also being a Black woman, are very real. I'm at a place in my life where I'm acknowledging these things are real. Discrimination is real. The systematic oppression of Black people is very real, but I will succeed in spite of that.
The police force is foundationally racist.
Well, there's definitely a history there.
I want to start off by saying I don't
and Brav, welcome. Thanks so much for passing by. Much appreciated.
think that every cop out there today is racist.
Same.
I think there are a lot of them who are really doing good work. What I know from the establishment of the policing in the United States, that is directly from the slave catchers who were hired to catch runaway slaves and bring them back home.
Yeah, I agree that all cops aren't racist. I had plenty of interactions with police that were fine, but I was told by a former police officer who was, a cop who decided he didn't want to do that anymore, that, the training is pretty much specialized for only colored people, especially Black people, that if you're around them, they're the most dangerous, so you have to act in certain situations or react in certain situations,
I think I just really want to emphasize that I really think that there are some officers who are white that don't even believe that they're doing anything that may be racially motivated because they're simply doing what they were taught to do.
I come from a police family, and I like to add they do offer diversity trainings in the academy. So either it needs to be more extensive, or maybe we need to take it a step back and fix the selection process, because that process could be inherently racist. Hello, my name is Nia, and I am Black. I'm proud of my race because when I look back historically at what people of my heritage have gone through, and to see where we are now, it's remarkable, and it definitely pushes me to continue to be resilient and innovative as they were.
Historically, people formed groups, villages. Some people were hunters, some people were farmers, and then you had whoever was going to protect the group. And over hundreds of years, thousands of years, whatever it is, that's how we wind up having cops, firemen, armies, and navies. Community policing as a theory is a good idea. As a practice, it has some hiccups. When I show up at your house because you and your husband got into it and he beats you up and I'm friends with him, so do I want to take him to jail? He's my friend. Or I live in the same neighborhood and I go deal with some guy who's a really bad dude and he says, I know where you live, I know where your kids are. So to some degree, we have to have a little separation. This is going to get into a hot button topic, but I will tell you that, when I watched the horrible video of George Floyd, I will tell you that I can justify many of the things that happened, but I cannot justify 9 minutes on his neck or back. But what I can also tell you is I, as a policeman, and this is my personal opinion only too, the officer who was on him for 9 minutes, he probably spent too much time in the same neighborhood dealing with the same problems over and over again that he became jaded.
Isn't that what being a police officer is?
Yeah.
That's the problem with a police officer then, at least in my opinion.
Social service job.
And you're assigned to that district or that community.
But I think you need to move around so that you get to see other things. You don't become that jaded.
The police, no matter what your race is, we have to be integrated all together with the community. And it doesn't have to be community policing, but we all have to understand each other more. I think cultural competency would be very helpful. Like, that's my issue.
If you want to say, what exactly are you confused about, Oily Olive?
Whether or not
Or like, what are you questioning?
Foundations of the police force was or still was racist. Now we can change that, but it starts with cops. Like, at the end of the day, it's the bad police officers that are our issue. Not all police officers, but the bad police officers, we need to vet them out, and the good police officers, we need to, encourage them to be amongst the community.
How do we vet them out?
By making the police unions accountable, because I feel like that demographic of officers, they're actually making things a lot worse for the other officers that are actually just trying to do their job. I think that we need to get some type of real accountability. That I don't think the police should be policing themselves. So when those cops that aren't upholding their oath, they can be properly removed instead of getting all of these passes.
The bad police officers, I hate the term like the bad apple. It's like, no, you're a faulty grenade. Like, you're ruining your whole department reputation. I feel like I was held up to higher standards working at Whole Foods sometimes. I got 3 chances out, but like Derek had so many.
17 reports before George Floyd.
17 reports. It's like, get him out of there. What are you guys doing?
Do you think police officers, and I genuinely am curious, do you think they should get paid more?
I think police officers should get paid more. I also think police officers should do less. Why do I get sent to all of the mental health cases? Why do I get sent to all of these things? Now, I'll tell you why I get sent to them, is because we'll stop sending the police there, and then something horrible and tragic is going to happen, and they're going to say, why didn't we have a cop there?
Do you think we need to have different divisions like mental health and just other, or maybe even specific police that are just for the schools? Like, do you think that that would help with a lot of the issues?
No. We do have special...
Are you referring to the officer that they're talking about, like the officer that got jaded? And I'm curious as to what you mean by the old way. I'm not sure that officers are trained that much differently, whatever, compared to like 10 years ago.
Specialized police officers in certain things. But if we keep specializing And we get so compartmentalized that I can't go, I'm right across the street from you when you're screaming for help. Yeah, that's not what I do. Got to go find the guy that deals with screaming women or whatever it is. My name is Jimmy, and I am a retired police officer. I'm not going to tell you that there are no racists on the police department. I don't think blacks were historically treated fairly under the law. I think that we have made great progress, great strides. I think we have to continue to get better, but I also think we probably see racism to this day in places where it maybe isn't.
I sometimes wish I was a different race.
Interesting question.
I'd say not so much these days, but definitely 100% when I was a kid, I wish I was white. I grew up with my white mom. I didn't see my black side of my family after a certain point. I grew up in a small town. I was often the only student of color, definitely the only black kid. And I had this kinky hair. I couldn't figure out how to work with it. And everybody also would call me an Oreo. It was always just being othered. And so being a kid, you know, you just want to fit in. And for me, I wanted to be white. I just wanted to look like my mom, wanted the nice straight hair. And I just wanted to feel like included.
Yeah, I remember in elementary school, I was thinking, no man is ever gonna like me because I freaking look like this. And I just remember hating my hair because as soon as puberty hit, it just blew up, and people kept on asking, do you even need a pillow to sleep at night? I'm like, I can't stand these questions. I can't do this. I'm Jordan, and I am biracial. I think being biracial is definitely living in the in-between, because culturally, yes, I grew up white and I completely know that. I was raised by my white mother, but then there's also a part where race is perceived, and it's what people put on you and how they respond to you in your everyday life.
It's so interesting because I grew up in predominantly non-Black communities, and for some reason still being the minority at home in the family as well as in school and in the world, I was always so proud to be Black. I actually really yearned to.
Okay, I see what you mean. Oh, okay, you're talking about, yeah, the whatever. The knee on the neck or the back, George Floyd. Now I understand what you mean.
Be around other Black people. So thankfully
I mean, yeah, the fact that that type of I don't know, restraining, I don't know that I would call it restraining, but that technique as a way to incapacitate someone, the fact that that was ever taught at all seems pretty I don't know, barbaric to me. I'm not a police officer.
College, that was an experience where even though we made up a small community, I was still able to, okay, this is people that look like me.
I was in the military for 6 years, and I was usually the only Jew in my battalion. And I think that isolation produced a sort of pride and understanding of who I am and where I come from. So
I have never wanted to be anything different than what I was, but that's because I really never thought about it. And to your all's point, maybe, I don't know, but maybe people
Jimmy White
treated you that way
can't help but laugh at that.
Because there is this sense of wanting something that I haven't ever had before. I'd love to have a Lamborghini. You know what I mean? It's different than any other car I've ever had. It's different than what I grew up with.
I think personally for me, I was actually adopted by white parents in very diverse family. I think 6 out of the 8 of us are all adopted, all different races. I kind of have my own story apart from everyone else. And the same for everyone else that was adopted in my family. They have their own story. I always had pride in it, but at the same time, my parents are my parents no matter the color of their skin. It's the people who raised me, and they raised me just to not look at it through the lens of race, and that's what I've always done, and I've never wanted to change my race at all either. I'm Joshua, and I'm Black. I've never experienced racism. I've experienced stuff from people from my own race. I grew up in a white family by white parents. I was constantly called whitewashed. It upset me, but I didn't let it get to me. Being black in America, to me, is just being an American in America, just like any other person.
White privilege exists.
I mean, America was founded by
Looks like everybody agrees here.
white people, for white people at the time. All of the institutions were designed to benefit white people. So, I mean, of course, white privilege lingers into society today. You can't deny that.
Where I would argue with you just a little bit is I think we throw out the term white privilege far too often for things that aren't necessarily white privilege.
I've got to agree with you completely on that one. I think there's generational white privilege for sure, but I think now it's almost used as a reason to not try as hard. If we stop doing that, just really like work for it and not use white privilege as an excuse, then we could really get somewhere as in the black community.
I would respectfully disagree. Like, all of that is true to an extent. Like, I graduated university during the pandemic, the height of it. I went abroad for university. I got 2 degrees. I graduated with honors. Learned to speak 2 languages. I should have been able to get a job right away, right? No. It took me 9 months before I was able to get a job. Had to go completely outside of my field. But then when I looked at all of my white colleagues who were in my program, all of them were hired immediately.
I need to introduce you to my daughter. She's white. Took her a long time.
And I'm not saying that. I'm saying just
she didn't get her job in what her degree is in either.
I respect that, but my point is saying me comparing myself to the white students who were directly in my position, they're successful, I'm not.
This country was founded upon white people coming and then putting in act Jim Crow and other laws saying that if you are not white, you are genetically inferior. You are not even a person. And some of those laws are still, and those systems are still in place today. 2 things can be true. You can have had a very hard time. Privilege is not just limited to white people, but to say white privilege doesn't exist from a historical context, to me, is respectfully absurd.
Something that I learned about recently is the privilege that exists in the medical field, specifically relating to the birthing process in giving epidurals. There was a study that's recently, or was debunked, that said that Black people have a higher tolerance for pain, which then has been falsely used by people who help support births in being hesitant to provide the epidurals for Black women giving birth. A lot of women die in childbirth. I don't know the exact statistics. So
3 times more likely Black women are to die.
Thank you. The fact that I will be taken seriously, more seriously than a Black woman in my place if I should be giving birth at some point, I see that as just an absolute privilege. My name is Bryn and I just graduated and I'm currently gaining hours to becoming a licensed therapist. As a therapist in school, we were taught to approach things with what's called cultural humility. Cultural humility is being curious, and instead of trying to have all the answers, working collaboratively with the client to kind of understand where they're coming from.
I have been fetishized for my race.
Question.
You know, the standard one, oh, you're pretty for a Black girl. I'm like, that's not a compliment. That's so weird to say. And like one of the go-to pickup lines for men, they're like, oh my God, what are you? I'm like, this is not cute. I'm tired of having this conversation. This is lame. Yes, I know I have green eyes, hazel eyes. Like, let's move on.
I think Black women in particular are just extremely sexualized and fetishized. Every day I go out, I'm making sure that my outfit is, okay, because I don't want to draw certain attention. The way I wear my hair, if it's in an afro, if it's in puffs, if it's in braids, I'm going to get treated differently. Yeah, every single day something happens.
So there's a form of positive anti-Semitism where Jews are perceived as like being put together, coming from money, being doctors, lawyers, and women are attracted to those sort of things. And then also too, like all Jewish men are circumcised. Some women have that preference. So I've definitely experienced it, but I feel like it's a sort of subtle, trivial thing. Like it never really bothered me, but it's occurred nonetheless.
Yeah, I've had experiences in high school, college. You know, people ask me to stop me, mainly women. Like, oh, are you Egyptian? Or are you black in this or black in that? There's always something, it's always black in something else. And I'll let them know what I am, and they're like, oh, that's exotic or something crazy. You know, my name is Dino, and I am biracial. I don't want people to think that I'm like split between being black or white. I acknowledge that I'm mixed and I'm biracial, but for the most part, growing up, I was always considered black. I consider myself black. My family did as well. So I don't think we should live in a colorblind society, but I also don't think we should stay stuck and feel like we can't move forward and still thrive and accomplish things because of our skin color and where we live in America.
I would just have a question for everyone who stepped forward. I'm just curious how that's like. What's it like?
Exhausting.
It sounds exhausting.
Yeah, I think Black women historically have a really interesting relationship with desirability. Culturally, it seems as we're not desired. And then when we are, we're being fetishized. So it's like, okay, we're usually not desired, but now we are. Am I supposed to lean into this fetishization?
I think just being a woman, we deal with certain things every day. Specifically being a Black woman, being fetishized, it's interesting because if I, especially in my industry, because I'm there to work and be professional, I'm just super professional and I don't give any attention to that at all, that kind of energy, then I'm an angry Black woman. So I think that it's just really...
you can't win.
It does feel like that, so yeah, that you can't win sometimes.
Yeah, and there's also a flip side to it. It's like, for me specifically, I'm light-skinned amongst majority dark-skinned people, and people will deem me or deem other light-skinned people as a certain way, as either weaker or less than, or just like, okay, you're lighter than, so we're going to be so pro-Black that we're not going to consider you as one of us, you're just other.
Well, that touches just on beauty standards in the Black community, and that's colorism. Like, I've even been told, you're beautiful, you're not Black. It's just like these little things.
Yeah. Or you must be mixed with something,
yes.
right?
Yeah. My name's Christina, and I'm biracial. I have been fetishized for the color of my skin on both sides. Black men will be really into me because I'm light-skinned, or other men who are not Black might be into me because I am that Black girl, but maybe I'm not too Black, and that, for whatever reason, is appealing. Being deemed as exotic or something other is just very problematic, and that plays into a lot of issues of colorism within the Black community at large.
We need reparations for the Black community.
I would say I'm in favor of reparations, personally.
I don't think people...
Generally speaking, no. At least, to fetishize another person, when generally speaking, most other people don't want to be fetishized unnecessarily, or like, against their will, so to speak. Basically, generally speaking, not a good thing. And I would discourage anyone from engaging in that type of behavior or treatment, I should say.
People need individualized paychecks. Like I don't think that's gonna work. But I think pouring funds into communities who could really use it.
Okay, gotcha. My apologies, Oily Olive.
Building jobs there, more education there, more opportunities would do so much. That's how I see it should be.
Anytime that Black communities in the US try to, pull themselves up by the bootstraps, they were attacked. I think it was in Tulsa, they bombed the city. Black Wall Street, it was completely destroyed. So again, something needs to be done.
When the Civil War ended, there was a representative from Ohio, I can't remember his name, but he was a radical Republican and advocated for the phrase 40 acres and a mule for every emancipated slave. So there was supposed to be reparations, and there never was. And I think especially as a Jewish person, Jews received reparations for the Holocaust and are still receiving them. And in my mind, there's no amount of money that will ever undo the wrong of the Holocaust. So that all the money in the world will never make it right. But I think the idea and principle of reparations is good. Logistically, I don't know how it would happen.
I just wanted to say the reason I stayed back was because I wasn't entirely sure what was meant by reparations, but your example of the Holocaust, I would say that I agree.
Similar reason, when I think of reparations, I think of something similar to a stimulus check. My worry is, with the lack of financial literacy, will we actually make strides? So I would love the idea of investing money into programs in underserved communities, something like that. But I do have a fear that even if we did have the money, without that generational knowledge of how to take care of our finances, that it would just deplete and defeat the purpose.
But even if that were to happen, though, I still think that that would still be the right step. We'll give these people the funds or whatever, we'll give them our promise, and if they float or sink or whatever, that's on them. At least we as a country took the right step.
I'm all for money going to the community. I am for that because the communities right now are the way they are because of things in the past. But to give out checks to individual people, there's a difference between learning from the past and then still getting caught up in the past. I mean, if I had a time machine, I could go back in the time and be like, hey, you never gave us the 40 acres and a mule. I would be all for that, and I would get on that for the people who were affected and actually went through slavery. But in today's age, no one's experienced it and gone through it. Yes, the communities are taking hit by that, but so I mean, I've never.
You don't think your ancestors experienced slavery?
I think they do, but I haven't. I've never been in it, so why should I get a check from somebody else who never put it? You should be going way back.
So what about the people who are the descendants of the slave owners who are still reaping the financial benefits of your ancestors who slaved in those fields for literally generation after generation? You don't think that during that time, your great-grandfather could have been building a business that could be flourishing by now, and you would have a multi-million-dollar franchise as they do off the backs of others? You don't think that deserves some rectification for you in the present time?
To be honest, no, because again, it's something that happened in the past. Again, I haven't experienced it. I'm doing fine right now. I'm doing fine, and I'm not going to be all upset over somebody else's ancestors who I don't even know who enslaved my ancestors. I don't need it. I have no reason to have it.
So for me personally, I'm not upset about it, but I do feel my grandfather, on his side, they were the first family in the state of Texas to actually file for reparations. And for me, I'm succeeding in spite of that. But to this gentleman's point, when the government says, hey, we're gonna do a thing, obviously the government in itself saw the weight in the air of the wrong, just as the German government did. I think if I want to buy 90 gold chains, that's my business. I think it would be unfortunate, but I think that if I'm entitled to something, I think it should be in the same fashion that the people of Jewish descent got it. I think it should be in the same fashion that the people that are Japanese descent got it. So you might think it doesn't affect you, but overall, I think that we have been greatly impacted by slavery, even up to current. I just choose not to focus on it nonstop so it doesn't become something that holds me back. But I definitely think it's something that we are entitled to.
Thank you.
Great, guys.
This is this is one of the, at least in my opinion, this is one of the few Jubilee videos that I think was pretty good. Had some productive conversation. And yeah, I think it was both entertaining and informative. For me personally. I find Jubilee videos can be hit or miss. Mostly miss, and the occasional hit. I think this is up there as one of the exceptionally better ones. Is fetishism good, bad, or neutral? As in there's both good and bad to it. I liked anime and so into Asian women, but still treat them as humans. Well, yeah. But other treat it beyond and make it yeah, so that's the line in my mind, Oily Olive. You're attracted to what you're attracted to. Generally speaking, you don't have much control over what you're attracted to, although sometimes you should question what you are attracted to and question your values. Totally. And so yeah, if you are attracted to, Asian women, that's what you're attracted to. And so there's only so much control you have over that. But as long as you recognize that there's the line between being attracted and fetishizing a person or an ethnic group or whatever demographic, as long as you're walking that line and you're just treating them as humans, and you are not, going into the territory of fetishizing, then I think you're being respectful, and you're going about it in the right way. I would generally err towards fetishism being bad. That would, generally speaking, discourage anybody from engaging in that, because, well, you have to take the other party into account, and it's generally, I would say, pretty disrespectful. And so the fact that you're aware of that, I think that's a good thing. And I would, really try to lean into just treat every human as human. And that should be your guiding principle. And just as the result of maybe some attraction, that should not necessarily mean, or that should not mean, that, you go above and beyond, or that you go into that territory of fetishizing that. So that's going to be it for this stream. Let's see if I can find anybody to raid out to. I think Jason Society is doing their Stoner Cast right now. So we're gonna raid into that. And yeah, if Jubilee is starting to do stuff like this consistently, great. Because I think a lot of the stuff, their stuff in the past has been absolute trash, in my opinion. So yeah, that's gonna be it for this stream. I will be back on Tuesday. I plan to be back on Tuesday, doing my usual fitness workout stream, and then a stream in the evening. I'm still deciding on what I want to cover, but I have absolutely no doubt that I will find something to cover. There's always some science or some news or a combination thereof that I can go over. And so with that, I want to thank everyone that passed by. Oily Olive, always a pleasure. You always ask great questions, and always bring good conversation. Chutoy, thank you to Bob Marley for passing by, and also that study. I'm going to save that study and cover it probably on Tuesday stream. And anybody else that I'm forgetting. Oh yeah, I know I'm forgetting a bunch of people. Bruv27, thank you so much for passing by. Wick, Death of Certainty, thank you so much for passing by. And Armed with My Opinions, thank you so much for passing by. And anybody else that I've forgotten, thank you so much for passing by. Going to, raid out into Jason Society. They're doing their Stoner Cast. They're, in my opinion, a based leftist streamer. Give them a follow. Support them. They do good stuff. And until next time, take care and be well.
Oh shit. Yeah. Fuck your test. I'm banging. Corey Campbell's here.